Good afternoon, everyone. Thank you for joining us. We are so excited to be back here in person for ALC. Thank you to those of you who stuck with us for the past 2 years of virtual conferences. Nothing beats the collaboration and conversation that comes out of all of us being here together for these important discussions, even though this is hybrid and there are people watching from various places. I'm thrilled to be co-hosting the Health Braintrust today with my colleague, my friend, my sister, my twin, Congresswoman Lisa Blunt Rochester. Lisa has been a champion for expanding healthcare access and making our healthcare system more equitable. Today we have 3 fantastic panels organized to discuss some of the most pressing healthcare issues for Black Americans. First, we will start with mamas, ensuring access to abortion for Black women. We've been so outraged by the Dobbs decision, but we are turning that outrage into action. For months, we have been working to identify opportunities to continue supporting abortion access, especially for women in the South and Midwest who will now have to travel to access abortions. Not Kansas or Illinois, I will say. Of course, we know this decision will worsen the Black maternal mortality crisis. So I'm hoping today we walk away with some ideas about how to support maternal health care in this moment. After our first panel, we will move into approaching gun violence as a public health issue. In 2020, Reps. Cori Bush, Carolyn Maloney, and I worked with Senators Elizabeth Warren and Ed Markey to request a Government Accountability Office report on the public health impact of America's gun violence epidemic. Last year, we received the results of that report, which confirmed that the gun violence epidemic disproportionately harms Black and low-income communities, and that it costs the U.S. healthcare system more than $1 billion, yes, $1 billion every single year in treating initial injuries alone. Finally, we will close out today's Health Braintrust with a panel about successful strategies for addressing substance use disorders in Black communities. According to SAMHSA, in 2020, nearly 27% of African American adults had a mental health issue or substance use disorder. That comes out to more than 8 million adults. From 2015 to 2016, overdose deaths grew by 21% across the overall population, but increased by 40% among African Americans. The data shows that there is something that we are missing or not doing right to treat substance use disorders in Black America. Hopefully, our discussion today will help eliminate some stigmas, correct misperceptions, and result in some solutions that we can walk away with. I want to thank each of our wonderful panelists and moderators who have taken the time to be here and share their expertise with us today. These are truly experts. I'm eager to hear from them, and I'm sure you are too. I also want to thank our sponsors, Blue Cross Blue Shield and Sigma Gamma Rho Sorority. Thank you, sorors, for being our sponsors for this workshop, or this Health Braintrust. And with that, I'd like to turn over the mic to, again, my friend, my sister, my colleague, the wonderful Lisa Blunt Rochester, to get us started.
Good afternoon, everyone. That was beautiful, just to even feel that love and get that love back. I am Congresswoman Lisa Blunt Rochester, and I have the honor of representing the entire state of Delaware. Robin and I always talk about the people we represent are urban, suburban, rural, and in our case, also coastal. And so it is a pleasure to be here. I also have the distinct honor of being Joe Biden's Congresswoman as well. So I am the President's Congresswoman. And I am also excited to be co-hosting with Robin Kelly. She is a true champion for every issue that affects us today, everything from maternal mortality to gun violence. She always steps up and leads. And so I am so happy to be with her. She is the vice chair of our Energy and Commerce Committee, which is one of the most important committees in Congress. Well, we say it is the most important committee in Congress. And so I am happy to be working with her. And we call each other twin because we have a lot in common and we also think a lot alike. And so just because we're nice, don't get in our way. Just want to share that. We have some remarkable speakers lined up for you today. on the panels. And the focus, as Robin said, will really touch three challenges that are really the most pressing facing the Black community. From the rise of gun violence in our communities to Republicans in legislatures and in Congress really attacking women's reproductive rights, the exacerbation of Black maternal mortality to the growing overdose crisis. It's up to all of us to address these issues with awareness, acknowledgement, action, and accountability. And lastly, leadership. These disparities in healthcare quality, access, and outcomes we as Black people face every day. And the pandemic just heightened those disparities that we already knew existed. And that's why it's critically important that we, and I say we, the Biden administration, elected officials, health professionals, advocates, community leaders, families work together to meet this moment and deliver solutions to improve our communities. And we are here today to talk about solutions, but we also want to talk about some that Congress has already focused on. First, the House of Representatives passed legislation to safeguard the fundamental freedoms of women to make decisions about their own lives, to preserve access to contraception, to protect women who now have to travel, as Robin said, across state lines to receive abortion care. We're fortunate in Delaware, and we have one of our champions who will be up on the panel to present that we are protecting it. But we know in many places across the country, we are under assault. And to protect those healthcare providers also, we want to make sure they're safe. Because as I said on the floor of the House when I gave my testimony, there is no room in our wombs for politicians. I'm going to say that again. There is no room in our wombs for politicians. Second, we will be looking at the gun violence epidemic in America, but we're going to be doing it through a different lens. We're going to do it through a public health lens, the lens that we should have been focused on as a country. We passed in the House historic bipartisan Safer Communities Act. This legislation was one of the most significant piece of legislation in 30 years. Robin Kelly, a true leader on this legislation. And it incentivized states to enact red flag laws, close the boyfriend loophole, enact enhanced review processes for those under 21 to purchase guns. And it also supports important community-based violence intervention programs that are evidence-based to help us address the root causes of violence permeating throughout our communities. Lastly, we know that there is an overdose crisis impacting America, and my home state of Delaware consistently ranks among the states with the highest overdose death rates in the country. I put a pin in this because a recent CDC analysis found stark racial disparities in drug overdose deaths, which now disproportionately occur among Black and Indigenous people in the United States. Even the opioid epidemic, I think a lot of people thought, oh, that's not our issue, because initially we weren't being prescribed pain medication. But now this does disproportionately affect us. And so that's why it's important that Congress act in this session to pass legislation to help communities with the resources to address prevention, treatment, and recovery. With these issues, while these issues may seem far away from each other, they really are connected, because they will allow us to live free from the burden of disease, injury, and violence. And that's what's critical here, reducing health inequities and closing the gaps in health outcomes. I'm looking forward to exploring these important issues in depth and hearing from the panelists. And we are excited. I also want to acknowledge again from the state of Delaware, State Representative Melissa Minor-Brown, who is a champion and you'll hear from on the panel. I thank her for coming. And I thank all of you for tuning in to this very, very important session, the Health Brain Trust, that will have 3 sessions. And now it is my honor to introduce by video CMS Administrator Chiquita Brooks LaShore. She is the administrator for the Center for Medicare and Medicaid Services, where she oversees programs like Medicare, Medicaid, the CHIP program, Children's Health Insurance Program, and healthcare.gov, the health insurance marketplace. She is the first Black woman to lead CMS, and she is an outstanding leader on healthcare issues and a fierce advocate for health equity. Now, let us hear from her, and let's hope the technology works. I told you, okay, now I cross my fingers. Now we're going to just pray. Let's pray that the technology works. Robin Kelly just said I can sing. That is one thing Lisa does not do. I can dance. I will do a Beyonce thing right up here, but I cannot, you will not get me to sing. Well, what we might do is go ahead and start with our panel, and as they work on the technology, we'll let our administrator come on. We're going to transition now to our first panel, and we'd love to have the panel start approaching the stage. It's my pleasure to introduce Amber Ray, the moderator of our first panel, Supporting Mamas, Ensuring Access to Abortion for Black Women. I call her Dr. Amber. She doesn't love that, but I call her Dr. Ray, Dr. Amber, because she is my health policy advisor, but she provides a unique perspective in Congress as one of the handful of pharmacists working on Capitol Hill. So we are blessed and honored to have her here, and she will be moderating our first panel. Welcome, Amber, and thank you all for being here.
Good afternoon, everyone. It's good to see you, and thank you so much, Congresswoman, for the introduction. You know, I think the Congresswoman is so inspiring to me. She is one of the fiercest advocates for health. She's so passionate. Whenever we get out of meetings, people often say, that is the best meeting we've ever had with a member of Congress. And although she does pay me, she did not pay me to say that. Thank you all again for attending our first panel, Supporting Mamas, Ensuring Access to Abortion for Black Women. As she stated, I'm the health policy advisor, and I'm a licensed pharmacist. And as a policy person and a healthcare provider, I believe this panel is important because the connection between the restrictions on abortion access and the impact on Black maternal mortality is something that is undercovered and something that is under-discussed. And so I'm thankful we're having this conversation today. Black women in the U.S. are already 3 to 4 times as likely to die from pregnancy-related complications than white women. And I might add that 80% of these deaths are preventable, according to the CDC. And to me, that is just tragic. And forcing a health condition with known negative outcomes by limiting access to abortion, something that the majority of medical associations support as a viable and needed treatment option, can have life or death consequences. So I'm going to turn it over to the panel, the experts, soon, but I would be remiss if I didn't acknowledge the contributions that the two co-hosts today, Congresswoman Robin Kelly and Congresswoman Lisa Blunt Rochester, have made towards reducing the rate of maternal mortality. I mean, it's incredible. Whenever we're in our subcommittee, our health subcommittee, the chairwoman often acknowledges the work that both of these women have done, you know, and doing so before it became mainstream and before everyone was talking about it. Congresswoman Kelly has been working on maternal health issues since 2017 and introduced the Comprehensive Mamas Act during the 115th Congress. This bill would address the maternal mortality crisis by funding many, many programs. And I might add that several provisions of this bill have actually been enacted into law. And to me, that is true impact, because it's not often that we actually pass laws in Congress, unfortunately. Critically, the bill would also extend Medicaid postpartum coverage from 60 days to 1 year, which is one of the provisions that I think public health experts across the country know is going to be the key to helping our Black mamas. And then, of course, we have Congresswoman Rochester, who's been a fierce advocate for improving maternal mental health. As the chief champion of the Moms Matter Act, this bill would support community-based organizations who are on the ground helping moms with their postpartum mental health issues. And, you know, there was a recent CDC analysis that found that the #1 underlying cause of death for these women, when you look across all women, is mental health conditions, so suicide and overdose. So this, again, is something that we really need to be discussing more and is important work. So now I'm going to turn it over to our panelists. I'm going to introduce them as I have them on my page, which might not be reflected up there. But Dr. Maisha Taylor is an emergency medicine physician who practices in Dallas, Fort Worth, Texas. Can you give us a wave? She's a strong advocate for increasing physician workforce diversity, and as a pioneer in this area, she is the namesake of the mother character of Doc McStuffins, which, if you have children, is a Disney show. So next we have State Representative Melissa Minor Brown, who's a registered nurse by training, and she serves in the Delaware General Assembly. She's authored several pieces of legislation to expand access to abortion in Delaware and to improve maternal and infant health. And I might add that the Delaware 2022 Omnibus Act recently passed into law. So again, another very effective legislator up here. Renee Bracey Sherman is the founder and executive director of We Testify. She's an activist, writer, and reproductive justice advocate committed to the visibility and representation of people who've had abortions in media and pop culture. I want to add that I read on her website, she is the Beyonce of abortion storytelling. And I couldn't not say that because if you know Congresswoman Blunt Rochester, you know about her love for Beyonce, so we hear about this all the time. And then last but not least, we have Dr. Rachel Bond, who is a board-certified attending cardiologist who has devoted her career to the treatment of heart disease through early detection, education, and prevention. She's also the co-chair of the Cardiovascular Disease in Women and Children's Committee for the Association of Black Cardiologists. Let's welcome our panelists. So I'm gonna pose the first question and then I'll sit down. I want to start pretty broad and to set the stage for the audience. Ms. Bracey Sherman, can you tell us what the top reasons are that women choose to get abortions?
Yeah, hi everyone. How are you doing? Hi to everyone who's online. So abortion. Should we say it all together so it doesn't make us all awkward? Okay, 1, 2, 3. Abortion. It's not a scary word. We can talk about it. As my t-shirt says, I had an abortion, probably like many of you who are watching or here in the room. There's no one reason that anyone has an abortion. It's actually a mix of a lot of different factors, a lot of different reasons that are often compounding. One of the top ones is actually economic. The majority of people who have abortions are people of color. They are already parenting, and they are experiencing financial and logistical barriers to healthcare overall, in particular abortion care. And so one of the things is that they're looking at their lives as they are with the children that they're already caring for and facing another pregnancy and deciding, can I continue this pregnancy? Is this something for me? And sometimes the answer is no. Some people are having their abortions in clinics. Other people have them at home through self-managed abortions. And I think what's really, really important, we can talk more about what all of those things are in a minute, especially post-Dobbs, but I think it's really, really critical that everyone recognizes the actual demographics of who has abortions, right? It's majority folks of color. But what we tend to see in the conversation is young white women. The average person who has an abortion is in their 20s. What we're seeing in the conversation actually doesn't look like who has abortions, like myself. So part of it is changing the conversation and actually centering Black and brown people in this work. Centering people who are already parenting in this work. Abortion is is a parenting decision. And then, of course, talking about the economic issues that people are facing when they're seeking abortions. And then lastly, I would just say that we need to have a deeper conversation if we're going to talk about maternal health, how important it is to have abortion be part of that conversation. If we're talking about people having complications at any point throughout their pregnancy, that means they need access to abortion and all of the medical care that they can receive, medical procedures throughout their entire pregnancy, and that includes abortion later in pregnancy. So I'll stop there for just a second.
And then I'll add, to your point, abortion. So what is an abortion, right? Because a lot of people have false ideas about what an abortion is. An abortion is simply the emptying of a uterus of the products of conception. And sometimes it's spontaneous. Sometimes there are products of conception left in the uterus that continues to cause bleeding and pain. They can stay there and cause infection and end the life of the mother. So it's not just a social issue, it's economic, but it's also very much medical. And it seems like that piece of the conversation is left out when we talk about the importance of access of abortion, safe abortion, in the space of maternal health.
You know what, if I could just, is this on? Let me take yours. I just want to piggyback off of that really quickly, and I'm sure the doctors on the panel could probably speak on this a little more thoroughly, but I like to talk about, you know, some of the life-threatening complications that come along with some pregnancies, knowing that 1 in 3 women with pulmonary hypertension die during pregnancy or childbirth. And just to make the decision to go full term in a pregnancy, the risk of going through a full-term pregnancy, being at risk for pulmonary hypertension is actually so much higher than an early-term abortion.
Yes, so as a cardiologist on the panel, I definitely want to highlight that comment. So there are several medical conditions that would be actually very risky for many of these mothers if they do become pregnant to actually go through the entirety of pregnancy. And that's why many of the medical societies are really stressing the importance of allowing the right to have abortion and have that intimate conversation with our patients. Because one thing that the limitations of restricting abortion does is it really threatens the sanctity of the patient-provider relationship. It's an intimate conversation that us as clinicians have with each individual mother to explain to them what their risks are. And pulmonary hypertension is just one of many medical conditions where the risk may outweigh the benefit, heart failure as an example, and a large portion of those are cardiovascular disease. And when we look at the leading cause of death when it comes to particularly Black women, when it comes to maternal mortality, it is cardiovascular disease. And as you mentioned, Amber, 80% of maternal mortality is preventable, but also 80% of cardiovascular disease is preventable. And I think we have to acknowledge the fact that we have to provide the options for these mothers, but allow them to also have the tools to make the right decisions at the end of the day.
Thank you so much. Kind of continuing along the basics, we understand what an abortion is, who gets an abortion, why they get an abortion. What are the legal rights or protections established in both Roe v. Wade and Planned Parenthood that have now been overturned? And I'll pose this to any of you because I know everyone knows the answer.
I can start, and then I'll just kind of pass it along. Yeah. So Roe v. Wade, landmark decision made by our Supreme Court in 1973, which actually struck down a Texas abortion ban to protect the women's, or to allow women the right to an abortion, and that just eventually, well, that became a law universally throughout the United States. And then I can talk about Casey, or someone else can if you want. I'm sorry that I do so much research on this now. I know Casey really spoke to 5 specific topics, like informed consent, spousal notification. So a woman would have to notify her spouse prior to actually moving forward with an abortion. I know there's parental consent for any child under the age of 16, medical emergency, to allow for a woman to have an abortion if there were if she was within a life-threatening situation. And then I want to say the recordation of records, or keeping records in reference to abortion. So I know those are the 5 things that Casey and Planned Parenthood basically addressed. Am I right?
You were right.
Okay.
That was like, I love it. It's like a little pop quiz. I think when the Dobbs decision came down, I don't think people really realized how much not just the right to abortion has the bottom and the like bare minimum that we had has fallen out, but also, in my opinion, and I think a lot of people's opinion, some of the bedrock of our democracy also fell out because it was protected, it was held up by the right to privacy. It was held up by the right to bodily autonomy. And so I think what's really frustrating is that people kind of didn't look at it and didn't pay attention because it's abortion, it's controversial. First off, abortion is not controversial. It's a gerrymandered issue, okay? It is not a controversial issue, first off. Second, because people are uncomfortable with talking about pregnancy and bodies and sex and centering the very people who need abortions, black and brown people, black and brown women, and trans and non-binary folks, like, they don't want to talk about that. So they pushed it by the wayside, and now this Dobbs decision is going to be used to undermine so many of our freedoms, whether or not, like, it's the right to marry, things like that, but also our right to free speech. As you saw, states like South Carolina are trying to criminalize talking about self-managed abortion. I actually brought with me, because I like to defy the government, I brought the medication abortion pills with me because I want you to see how simple it is. It's just a simple little pill. This is the mifepristone pill. It was introduced into the United States 22 years ago today. So happy little birthday to you. And then it's followed by these 4 misoprostol pills, which you put under your tongue 24 hours later, right? There's a state that's trying to criminalize me saying this. That is scary. I could be criminalized for possessing this. So something that I think is really important is that we think about the criminalization that comes with the falling of Roe, particularly towards black and brown people, just for the outcomes of their pregnancy. And as everyone talked about on this panel, just like how many things can go wrong with a pregnancy, and you go to an ER and you're facing criminalization because of the heightened surveillance and fear around whether or not, did you do something to your pregnancy? Did you cause that? That's really, really scary. And so I think it's important that we connect the criminalization, surveillance, and the need for health care for all.
And to piggyback on the criminalization piece, imagine being a physician and not being able to offer a full spectrum of healthcare options to your patients because you may be criminalized and penalized. And they did a survey on CIRMA, which is a large online community of physicians, and almost 90%, so 89% of them said that they would err on the side of legal protection before making a medical decision that goes against what the law says. So you can imagine, like, you're a woman, you're coming in with a maybe missed abortion, right, or a miscarriage in progress, you're bleeding. At what point can the doctor defend herself to intervene? How almost dead do you have to be before we're protected by these laws that say you can do it to protect the mother's life? So if she's going to die in a week due to sepsis, we have to wait that week until her blood pressure bottoms out and the antibiotics don't work? I mean, when are we protected? And because the doctors don't know, because it's not standard, we don't know when we can intervene. Literally, they said 79% of doctors are unsure about what this means for their practice. Everybody should be afraid.
And I'd just like to add also that I think this is going to have ramifications and a domino effect, as we talked about, even when it comes to physicians going into the field of obstetrics and gynecology, or physicians that may be in other fields wanting to have that collaboration with a lot of these high-risk mothers. I was fortunate enough last week to be at a meeting with the American College of Obstetrics and Gynecology in San Antonio, and this was actually a topic of discussion, that they are noticing already that several people that were interested in enrolling in residency programs for obstetrics is on the decline because of this decision. So this will have ramifications, and it's only going to unfortunately impact the most vulnerable, which are Black women in the United States.
And you can't even talk about it as a physician. You can't even give this advice, right? Otherwise, you're criminalized. I think that's the thing that really upsets me. And this is also in regards to sometimes gun safety. Can't ask about it. Do you have a gun in the home? Let's talk about putting it up. Like, we can't ask about that. So I think that we need, as physicians, legislation that is like a physician's Bill of Rights, so that we are protected and the sanctity of the patient-physician relationship is also protected.
When you talk about the ramifications, I also think about like the psychological impact of the woman and the family. And I think about how that's going to impact suicide rates in the future. You know, I experienced a loss once, and I remember having to go a week knowing that there was a lifeless fetus inside of me. And the nightmares that came along with it, the psychological trauma that came along with it. So I can only imagine a woman. I actually saw on, I was watching something, and this woman, she already knew that when she delivered, that her child was not going to live longer than maybe 72 hours, but she still had to go forward with that pregnancy. And I can only imagine how that impacted her psychologically.
People truly do not take seriously how painful it is to be pregnant when you do not want to be. Or when, like, you're saying that you wanted to end the pregnancy because it was not progressing healthy, right? Like, people do not think about the trauma and the impact of that. And I just remember, you know, I knew I had to wait a week before I could get my abortion appointment, and it was the worst week ever. And I did a lot of things to harm myself. And I think people don't take that seriously, one, because I think they don't, as a nation, we generally don't take mental health seriously, but we definitely don't take seriously the mental health and trauma towards women, trans folks, and Black and brown folks. And I really think that this is why we need a holistic health care system, not health insurance system, health care system.
Thank you so much. Ms. Bracey-Sherman, you mentioned earlier how the people who tend to get abortions, it's primarily people of color. There's a large proportion. But we also know that there's a lack of access to abortion services, reproductive health care services. So can you speak to that? Why is there such a discrepancy there?
Yeah, well, one, we have to look at root causes, right? I'm sure all the folks on the panel can talk about. It starts with lack of access to consistent health care overall, even prior to someone becoming pregnant. There's a lot of people. I was trained as an abortion doula early on, and obviously I work with a lot of people who have abortions, and for many of them, the first time that they've gone to a gynecologist is their abortion. They didn't have an opportunity to go for just a general health care, like a well woman exam, as they call them. Or they didn't have an opportunity to get consistent access to birth control. So people are going to have a disproportionate opportunity to become pregnant, right? And so then they may need more abortions. But what becomes challenging, too, is that as clinics are being forced to shut down by state governments, they're not being able to get the care they need in their communities. So some people are continuing the pregnancies, and others are having to travel out of state or, across the state, wherever, to get the care they need. I can tell you right now, I live here in Washington, D.C., although I'm from the great state of Illinois, shout out to the Midwest, but I've definitely cared for people who have traveled from Texas and Alabama, Georgia to D.C., but also from New York and Massachusetts and Illinois, because they cannot get the care that they need later in pregnancy, which again, I think is really critical to this maternal health conversation, because we should be making sure that everyone has access to the safe pregnancy care that they need throughout their pregnancy, and they should not have to travel out of their communities no matter what. So I think we really need to, as we rebuild post-Dobbs, I think that this gives us an opportunity, as really, try not to cuss, messy as it is, it gives us an opportunity to build something that is more holistic, actually centers Black and brown people at its core, and takes abortion care. If you make that the center and make sure that everybody has access to that care and it's the best, wonderful care, everything else will blossom from that. You will have people getting access to thoughtful, kind maternal health care throughout their pregnancy.
Yeah, so I just wanted to piggyback off of what you said. So as you noted, it's very, very uncommon that there is that ability to have preconception counseling. 40% of births are actually unintended, meaning that there really wasn't any thought in terms of knowing that they were going to conceive. With that being said, I think this is an opportunity for us to look outside the box and focus on those other areas where we could actually impact the maternal rates of mortality and morbidity with providing access to preconception counseling, bringing in primary care clinicians into the discussions to optimize a lot of the risk factors that do place mothers at a higher risk for poor outcomes like high blood pressure, diabetes, obesity, things that do disproportionately impact communities of color. But to the same point, we also want to extend postpartum care because we know that a key area when it comes to maternal mortality and morbidity actually occurs 6 weeks after the baby is born and up to 1 year. So a lot of our cardiovascular societies in particular, specifically the ones that I am very fortunate to volunteer with, the Association of Black Cardiologists, is doing a lot of work on getting the messaging out there about, as you made a very nice statement, about that continuum of care from preconception, pregnancy, if the mother decides to continue with the baby or not, and then postpartum as well. So I think that there's value to bring up those topics too, because I think that this highlights the disparities, but also areas that we could refocus our efforts on to improve outcomes.
I want to add one thing. In my bio, Amber introduced me as a reproductive justice activist, and I don't know that everyone fully knows what that means. I think sometimes people think it's a synonym for abortion or just means like I work on abortion access for people of color. I do that, but that's not what it means. Reproductive justice is a framework that was created by 12 Black women in the 90s, almost 30 years ago, that really focused on the fact that the choice framework was not realistic for Black and brown people across this country. Do you really have a choice if there's no maternity ward in your community, if there's no abortion clinic in your community, if you couldn't decide what you actually wanted to do with that pregnancy? If you're a young person and your family is telling you you have to get an abortion, but you actually would like to parent, where is the support to make sure that people have what they need? And so the tenets of reproductive justice are making sure that everyone has the ability and the resources in their communities and in their families to be able to decide if, when, and how to grow their families, and to be able to parent their own children free from state-sanctioned coercion and violence. And that means that the state taking children, that means that kids being shot in the street, particularly by the state, but also what we've seen in ICE detention centers and historically in hospitals, Black and brown people being sterilized against their will so that they cannot have children. So it is just as important and radical to make sure people have access to abortion, but also to make sure that they are able to have the pregnancies that they want safely, that they are able to make it through the delivery room and to be able to take care of their kids and have paid parental leave, to have that time bonding. All of that matters. And I know the conversation really always focuses so deeply on abortion, and that's critical, right? And I believe that we need to make sure people have access to abortion so that when they want to have a pregnancy, that that pregnancy is supported and loved and cared for, and they have the care they need.
And I think that that's important to mention the broader aspect of reproductive care, because like you mentioned at the top, Black women and maternal care, is abysmal in this country. In some parts of our country, Black women are 12 times more likely to die than white women. And that's crazy. And this is not counting for social determinants. This is across socioeconomic status, right? So white women who have not gone to high school have better numbers than Black college-educated women. So to exactly our points, it's disingenuous to say I'm pro-life, but you don't provide care in these communities prior to getting pregnant. And then we don't address the implicit bias and structural racism that causes us to die at higher numbers in this developed country, worse than any other developed country, and say, well, I'm pro-life. It's very disingenuous. So to your point, we need to work on this equity, maternal care equity across the board. So not just abortion, but reproductive and maternal care equity.
Yeah, and I want to thank you for mentioning morbidity, because that's something we really don't talk about. We talk about the maternal mortality, but we don't talk about the morbidity, and we don't talk about the near misses. And that's the thing. Like in Delaware, it's such a tough conversation because we're at the table. Delaware's so small. So the opposing side says to me, well, there's only been 8 maternal deaths. And I'm like, yeah, but they were all black women. But let's talk about the near misses, because they outweigh. There's so many near misses of women who almost died during childbirth, who almost died during the postpartum period. It's off the chart, and it's preventable. And the amount of women who died beyond 13 weeks postpartum is a whole other number. So that's important. But it's interesting because when we talk about the difference in the amount of black women that are dying in reference to white women, the thing is, if our clinicians could just follow protocol, you wouldn't have to worry about that. When you have a patient that comes in, and we saw it on Aftershock, and you look at their labs, and you see their hemoglobin dropping, and they're dropping, and they're dropping, and they're dropping. If you just follow protocol and do what you're supposed to do as a clinician, then we won't have this issue. So we're not asking you to treat us differently because we're black or treat them differently because they're white. I'm asking you to follow protocol and do what you were trained to do. That's it.
But I'm asking them to also treat us differently in that if you understand that you have a high-risk patient here, based on maybe she has hypertension coming into this pregnancy, or because she's a black woman and you have been trained on your implicit biases, then maybe you ask the nurse to take vital signs every 2 hours instead of every 4 hours, and you ask that nurse to contact you with that data so you can make real-time decisions, right? Because you know that this person is higher risk. So I'm saying, like you're saying, treat us the same. I'm gonna one-up you. No, I need you to pay attention to our numbers and our issues and listen to us.
Listen to black women.
Yes.
I'm just going to say, get the racism out of healthcare.
So I do think that brings up a very key point, that to date, our healthcare system is working in a silo, right? And I think the only way we're going to really tackle this is all of us, different either subspecialties, different clinicians, different societies, et cetera, working collaboratively together to try to really focus in on that, really what we are aiming for, which is to lower the morbidity as well as mortality. And just to put that into perspective, because I think it's important to highlight, as you said, morbidity outshines mortality when it comes to black maternal health. When we think about it, for every single death, there are 75 to 100 misses, possible misses, I should say. And that is mind-boggling to me. And that really highlights the fact that we should be able to prevent these very preventable conditions. But I think if we remove ourselves from what healthcare is right now, which is where we work very much in siloed locations and work more collaboratively, that will be a key way for us to really tackle this issue.
I want to explore that a little bit more. So we have Dr. Taylor, who's an emergency medicine physician. We have Dr. Bond, who is a cardiologist. Those are not two specialties you tend to think of related to women's health, yet you're here and you're an important piece of this conversation. So why do you think you are here? Why are you important? And then how do you think that the Dobbs decision will impact patient care and patient outcomes?
Well, I'll start since I'm ER. ER tends to be the front door, the point of access for so many people, especially in black and brown communities, because like we mentioned, there isn't a robust primary care apparatus in many communities of color. So they end up coming to me and my colleagues in the ER, sometimes not even knowing they're pregnant until well into the second trimester, bleeding, no prenatal care, high blood pressure, preeclampsia, all these other issues, right? So the reason why I think that I'm here is to share that this is relevant to emergency medicine. This is relevant to the community. And again, like I mentioned before, we are making decisions about life and death with this law hanging over our heads. when do we intervene, right? How sick, how low is the blood pressure before we can intervene? How septic is she before we can call in our consultant and advocate for treatment, and what sorts of treatments? I mean, honestly, a conversation I would have, like with a family, would be, okay, so she's bleeding. I can treat this blood loss. I can give her blood products, or guess what? We can let her bleed out a little bit. Maybe she'll be sick enough to call in the OB so that they can actually treat the patient definitively. That's a tough decision, right? Like, I have to wait for her to bleed enough to be close enough to death before I can be protected by law to intervene, right?
Absolutely. And to that point, when we think about abortion, we know that it is an essential part of healthcare. We also know that it does necessarily impact not just our reproductive health, but also our cardiovascular health. And when we think about, again, we touched upon this very briefly, that the leading cause of maternal mortality as well as morbidity is cardiovascular disease. As a cardiologist, I need to be at the forefront of that messaging. I need to be working with my obstetric colleagues, my emergency medicine colleagues, and primary care clinicians as well to really reinforce how preventable cardiac conditions can be. We know that there's an opportunity for us to better, I would say better treat and better diagnose, more importantly, many of these modifiable risk factors like high blood pressure, diabetes, cholesterol, obesity, things that really give us the opportunity to provide sound lifestyle recommendations in terms of diet, exercise, but access as well, right? I think another thing that is important when we think about really the drivers of what's causing this epidemic, or more importantly, this rising epidemic, I should say, is those psychosocial factors. We touched upon this very briefly, but as Black women, we have I would say, between the misogyny that may exist, the discrimination from systemic racism that may exist, all of that, what is that doing to our overall health? We know that it's impacting our inflammatory system. It's impacting our sympathetic system, so adrenaline, and all of that is causing premature cognitive as well as cardiovascular disease, making them extremely vulnerable. So I really feel, as a cardiologist, I do have to be part of this conversation and have a seat at the table. And as I really emphasize, is remove that siloed approach and working collaboratively, which I'm very fortunate to do, not just nationally, but also within my own healthcare system as well.
Absolutely. Thank you so much. So in our last few minutes before we turn it over to questions, since this is a policy conference, we have policy people, legislators. What recommendations do you have for us in terms of addressing this? Sometimes we talk about the use of midwives, doulas, advocacy organizations. What recommendations do you have for us?
Well, I was going to say you're a doula, so there is such value in the utilization of a doula, a midwife, a nurse, as well as part of the care team. We know that data has shown, particularly for the Black community, that doulas really help to reduce those very dire rates of mortality and morbidity. What a doula is, they're not a healthcare clinician. They are a pivotal part of the team, though. They're someone out in the community who could be the voice and could be the eyes of that particular person who has the experience, and more importantly, will be able to guide them through any stage of their maternal care continuum. It would be perfect if we could have a doula preconception. There's lots of research looking into the utilization of that to date. It also would be perfect to have them postpartum, but I would say that the pivotal point is during that pregnancy, because they do a phenomenal job in guiding, at least making sure that the mother is getting the appropriate care and management as should be fit for her, based on, irrespective of what her race or socioeconomic status may be. I'll let you expand.
I was going to say that having someone at the bedside, it's shown that the patient gets better care. So if the doula's at the bedside, amplifying the voice of the mother, right? Because we know we're not heard, so we need like 1,000 people like amplifying. Our pain is the same. Our skin thickness is the same, despite what the University of Virginia study and the residents and medical students there think. That is false. Our blood does not coagulate with more frequency or more easily than white people, right? So those biological differences do not exist. So to have a doula or a midwife or a nurse or a family member at the bedside amplifying the patient's voice, I think that that goes a long way. And also to serve as a witness, right? Because when you're on your own, it's hard to be the patient on the hot seat, even if you're a medical professional. Even if you're educating, you have a PhD or an MD, it's hard to be the patient. So having somebody at the bedside that can amplify your message, go get the nurse, serve as a witness, call up friends, get on Facebook, right, embarrass these people, I think it actually can serve a great role.
When we talk about doulas in relation to policy, I can talk about Delaware a little bit. With the 2022 Delaware Momnibus, shout out to our Congressional Black Maternal Health Caucus for the word Momnibus, which inspired this package of bills. But 2 of the 6 bills in the Delaware Momnibus are related to doulas. One of the bills basically tasks our Division of Medicaid and Medicare to come up with a plan on how they're going to reimburse doulas, and we're going to receive that plan November 1st. 2022, so I'm so excited about that. And we also, which this is such a game changer, we also have worked with the Department of Corrections, and this one of my bills actually allows for the department, well, it allows for women who are incarcerated and pregnant access to a doula and a midwife. And so when I approached our Department of Corrections with this, we came up with the thought that, you know what, let's create a whole doula midwifery program within the prison. So now we're working on creating this program so that women have access to a doula or a midwife. And also, some of the women who are incarcerated will actually, eligible women will be able to take this doula training so that when they are released from prison, they'll be able to give back and relate to another woman who is incarcerated and pregnant.
That's incredible. Thank you so much for your work on that. I want to make sure we get to at least a question. Sure, and I believe we have mics. Oh, yep, we've got mics on either side for you.
My name is, is it on? Is it on? Can you hear me?
Yep.
Yeah. My name is Gayleen Knoyton, and I have a company called Celebrate Healthcare, but I'm also a leader with the Virginia NAACP, and my congressman is Bobby Scott. But I want to say that let's get to the real root cause of the pro-lifers. Do you honestly think that they want more black and brown children in this world? And is it a 2-for-1? You get an abortion and you get locked up, so you got 2 people gone. The other thing is, I want to say is that, what are you seeing? Are you seeing the Jane movement? Because, you know, the Jane movement was way back, long before Roe v. Wade. Are you seeing the Jane movement being coming back again?
Yeah, I think to your first question, I'll talk about that in a second. So the first question, I actually think the anti-abortion movement was actually born, the modern one, was born right after Roe, but actually right after the desegregation of schools, Loving v. Virginia, and them losing Christian prayer in public schools. So it's actually not about whether or not they want more black and brown kids. It's actually that they want to be able to control if, where, when, and how we reproduce. Because there was a time in which black women's fecundity was priceless because it was making profits for people in this nation. And that flipped as soon as slavery ended, right? So it's actually about who gets to make that decision and the control. And then, of course, they do push abortion bans when they're concerned that black and brown people will have more children over white people. So what abortion bans are actually about is white people having babies. They're trying to force white women, right, to have children. So it's the supremacy there. So I think it's a little bit complicated. Anyway, I can talk about that all day. To your question about the Jane movement, for those who don't know, out of my home of Chicago, there was a number of women, particularly white Jewish women, but a couple of black and brown folks. I've had the honor of interviewing a couple of the Black Janes, and what they did was they provided abortions illegally pre-Roe. They first started out where they worked with abortion providers. One was like a chiropractor, and then they learned that the doctors that they were working with actually weren't medically trained, and so they just learned how to do the abortions themselves. And in the 4 years they were running, they performed over 11,000 abortions on their patients, and they never lost a single person. So I think it complicates the narrative when we think about pre-Roe. back alley abortions, things like that, because you did have some safe abortions then. Is that starting up now? Well, it's complicated. We don't need to worry about perforating people's uteruses. Like I said, we have abortion pills. They're things that people can get in their communities from either online or from doulas and midwives in their communities. Folks, it is criminalized in several places, so we have to be careful about who can give it out and when, but that is the way that people are able to get safe abortions, a la the Jane Collective, in their communities. I think what's important is that we educate folks in hospitals, particularly ERs, so that they don't get thrown in jail for admitting what they took, because there's no way to tell in your system. There's no test. But if police are told, we have seen so many people arrested for the outcomes of their pregnancy, stillbirth, miscarriage, and then, of course, owning up to having taken, using medication abortion pills. So that's really, really critical. And I think we should always just look to the bravery of the Janes and the risks that we're willing to take to make sure our community is safe in this moment.
I do just want to point out, Delaware is a safe haven. Delaware is a safe haven due to House Bill 455. We were one of the first states to pass an abortion protection law after the Roe v. Wade overturning. And we've also created first aid abortion funds, which does assist women with getting to Delaware and receiving whatever services that they need. But we also have legislation that passed. I sponsored the bill, and it actually provides protections for our clinicians. It expands access so that trained nurse practitioners and physician assistants can perform manual vacuum aspiration abortions, and it also provides protections for out-of-state women. So if a woman comes to Delaware seeking an abortion, it is against Delaware law to release her information to any other state. So Delaware is a safe haven.
Thank you so much. So I know we have a few more questions, and I believe the panelists will be able to stick around for a little bit for you all to ask your questions. But I want to thank you all so much. This was so informative, and thank you to the audience for your engagement on this. Okay.
Oh, you probably can't say it. Hi. Oh. Hi.
Go ahead.
Yep. All right. I'll be quick, I promise. Amber Sellers, hailing from the great state of Kansas. Yes, where we did fight August 2nd to say no, but we still have a lot more work to do. So my question is in regards to reproductive rights and reproductive justice, and the panel talked about it a little bit in regards to pre-contraception or just before we even get to the point of being pregnant and being prenatal, and things of that aspect. And so I just wanted to hear from a couple of the panelists just where does the conversation begin, or where do we begin to advocate for preconception work, building out my plan? We know that Black women we face endometriosis, fibroids, and oftentimes we're faced with two choices: either deal with it, birth control, or have a hysterectomy in your 30s or in your 20s. And so it doesn't feel like we are not even empowered to understand our own pre-contraceptive plan. And so how do we start to build that conversation, and how do we make, is it a three-prong approach? Is it a multiple-prong, collaborative? I just wanted you to speak to that, of how do we empower us as individuals to go into our doctors and say, here's the deal. I want to get pregnant. I don't want to get pregnant now. This is what's going on in my body. How do we create a plan together?
So in Delaware, we're actually starting these conversations in our middle schools. It's called preconception peer education. I work at one of our colleges in Delaware, and we actually are working with our nursing students. Our HBCU is doing the same, and we're working in our middle schools and high schools to provide preconception peer education to all students so that we can start the conversation early. So that's what we're doing in Delaware, to just kind of start the conversation on what exists, what the possibilities are, and what the options are. And I guess the doctors could probably speak to what the conversations you're having with your patients.
Well, I was going to add that an essential component to this, overall health care, preconception and through pregnancy and postpartum is going to be to increase physician workforce diversity, right? If we don't have people that we can connect with that understand or are interested in our health, then that physician-patient relationship is not going to be strong, and our issues are not going to come to the forefront.
Yeah, we're also trying to seek the guidance of our pediatricians as well, right? So having these conversations as early as childhood, not per se to give the options of what that preconception would look like in terms of the prevention of a pregnancy if they were to want to avoid, but more importantly, to optimize any of those risk factors that we talk about, the ones that very commonly cause these very poor outcomes. So optimizing blood pressure in childhood, cholesterol, blood sugar, weight, etc. So I think that there is a pivotal opportunity for us, again, to really move the needle in the sense of starting as early as possible and really thinking about women through that life course approach, from even in utero, as an example, all the way till they're elderly, et cetera, et cetera. So that's really where we in medicine are trying to change how healthcare is right now. And I think that that definitely is going to make a huge impact in what we're seeing.
And I think it's important that we don't blame the victim here, right? Sometimes some of these conversations enter into an area of Black women, you guys are obese, your blood pressure's too high, you don't eat right, and that's why you have these bad outcomes. But when we live in a country that was established with hierarchy based on human value, on skin color, right, and gender, it's not our fault that we necessarily have high blood pressure if our cortisol levels are so high, because every time we enter a space, they may reject us based on our hairstyle, right, starting in childhood. So this is not something where we want to blame the victim, and nobody said that, but I want to put that out there because sometimes these conversations, they enter into that area, and that's not the right approach.
And also as a lawmaker, it's important for us to take accountability as well. So we really need to look at health in all policies. We know that addressing a person's social determinants of health needs is the way to really lead to better outcomes. And I'm talking about clean parks, clean water, access to quality healthcare, access to healthy foods, but also, the elephant in the room, we're talking about racism as a social determinant of health. So that's something that we have to really look at head on. We have to really address it. We can call it implicit bias if it sounds better, but at the end of the day, we need to address the racism piece as well. And when we address the social determinants, then we will see better outcomes.
This is why we need reproductive justice.
Well, thank you so much. That is a good segue to our next panel. Once again, thank you all so much for being here. Thank you to the engagement from the audience and for the questions. And with that, I'm going to hand it off to Congresswoman Blunt Rochester.
Wow, that was, I don't know about you, but that was a dynamic, informative, substantive panel, and the panelists were phenomenal. I also want to give a special shout out to Amber. This was the first time she's ever moderated a panel, and she did a great job. She did a great job. And again, just phenomenal. I mean, I heard everything from Physician Bill of Rights to reproductive justice. We all got schooled. Morbidity versus mortality, equitable treatment in addition to equal, not just equal, equitable treatment. And also just the fact that prevention, this is preventable. And so I just want to thank this panel. I know for Robin and I, we are just really, this gives us fuel to be able to do the work that we do in Washington, D.C. It's now my honor to introduce our second panel of the Health Braintrust. And our moderator today will be Greg Jackson. And I think the panelists can just sort of start making your way up to the stage here as we transition. This panel will be approaching gun violence as a public health issue. And so please, panelists, come up. Let's give them a round of applause as they come up to the stage. Thank you very much. And I will say, I'm going to introduce our moderator who is on his way. He is in demand at one panel, and now he's coming up to our panel. And again, the moderator is Greg Jackson, and he is the executive director of the Community Justice Action Fund, a community organizer, a political strategist, an advocate, an avid mentor to local youth. That is Greg. As I mentioned, he's on his way up, and so as the panelists take their seats, do we have enough seats for everybody? Yeah, we're good? We're good? Okay. What I'm going to do is have each of the panelists introduce yourself. We'll go through a round of introductions, and then I want to start off with the first question, which is to briefly share what a public health approach to gun violence could look like from your perspective. So first, we're just going to go through the who you are, and then we're going to come back with the first question. So that gives you time to think. We ready? All right, we're going to start right here.
Absolutely. Hello, everyone. So I'm Arnita Holloman. I'm the Federal Affairs Director with Community Justice. I am semi-filling in for Greg until he gets over here. So I'm with Community Justice.
Hello? Oh, is your mic on?
Hello? Check. Test. Hello? Test. Oh. Hi.
There we go.
There we go. Hello, I'm Derek Gervin. I'm the Acting Deputy Director for the National Center for Injury Prevention and Control at the CDC. Glad to be here.
Thank you.
Good afternoon. I'm Donald Tyler. I'm a clinical psychologist and Director of Clinical Services for Chicago CRED, an organization that works to reduce gun violence.
All right, we got Chicago in the house. Chicago in the house. I am Franklin Cozy Gay. I am the director of the Violence Recovery Program that is a part of the Urban Health Initiative at the University of Chicago Medicine. I'm also a proud Cohort 6 Fellow for the Robert Wood Johnson Interdisciplinary Leaders work that focuses on looking at crime victim compensation as a form of structural reparations. And I'm the co-director for the 1919 Chicago Race Riot Commemoration Project. Thank you.
Hello, I'm Gary Puckrin. I'm president of the National Minority Equality Forum. We are a research and education organization based here in Washington, D.C.
So again, to the first question, if you all could just kind of talk about what is a public health approach to gun violence and gun violence prevention?
I don't mind starting. Well, I'll just start by saying violence in our community is a serious issue. Firearm violence is continuing to increase, particularly from homicides. And there's really no indication that things are going to get better unless we do something to address it at the community level. As I mentioned, I'm from Atlanta, Georgia. I grew up in the area. I grew up in a community very similar to the type of communities I think we'll discuss today. Those of you who know the area, I live in the Vine City English Avenue community, which has seen its fair share of violence, unfortunately. But I do believe public health has an essential role to play in addressing some and reversing the trends that we're seeing, even in my community. CDC, we take a three-phase approach to addressing violence and firearm. We collect data, we conduct research, and we implement evidence-based practices. Data collection allows us to understand the problem at the community level, helps us to understand which groups are disproportionately impacted, where the violence is occurring. Even in our strategies, when we conduct evaluation, we know how well those strategies are being implemented. Research allows us to develop solutions to address some of the problems we're seeing, and then we work in partnership with communities to implement those proven strategies. And so public health has a long history of doing this and working with multiple sectors in the community to ensure the health and well-being of our community members.
Dr. Gary Slutkin, the founder of Cure Violence, a professor of public health at the University of Illinois at Chicago, I believe he put it best. He said we need to approach violence reduction the same way we do disease control. We need to detect and interrupt conflict. We need to identify and treat the highest risk individuals. And we need to change community norms. And at Chicago CRED, this is what we focus on, those three components, essentially. Right, and so our mission is to achieve a transformational reduction in gun violence in the city of Chicago. We do that by employing teams of outreach workers, life coaches, case managers, and therapists who work directly in the communities that are most impacted by gun violence. So we're on the ground every day in our communities, on the blocks, working directly with those individuals who are shooting and being shot to give them an opportunity to come out of the streets and change their lives. And so that's where it begins. As we go along, I'll say a little more about that work.
Thank you. So why public health and violence? So often when I talk to students, whether they're graduate students or undergrads or high school or elementary school, I would like to provide context of what we're talking about. In the late 19th century, some of the same things that we're talking about today around life expectancy was an issue in the late 19th century in Europe, in particular in England. And what happened is that individuals were being blamed. They were being blamed for their morals, their hygiene, and it actually took a public health epidemiologist who was interested in understanding the distribution and the causes connected to cholera. And it was actually viewed through an examination that if we go out and we look at the environment, we stop blaming individuals. Let's look at what's happening in the environment. Actually found out that upstream, someone was dumping waste in what would be someone else's drinking water, right? So that's the 19th century. Let's go to the middle 20th century. And I often say this. I'm going to read this statement to you. Blank doesn't kill people. People kill people. What do you think fill in the blank for me? What is that? So actually, this statement was from automobile lobbyists in the 1950s and 60s, and they said cars don't kill people, people kill people. So again, what's the theme that I'm getting at? Why is public health important? Because public health is a perfect frame to say, let's not blame the individuals. Let's look at the entire environment. We know, talking to our students, we know seatbelts, we know airbags. Our younger kids today will tell you lane detection systems. You know, they'll tell you cars that stop themselves. So public health is saying that we have a social responsibility to collectively approach a health problem or an environmental issue that is impacting health. Public health is important because it understands that we need to look at the entire ecology, not just the individual, not just the relation. It's not about what mom and dad are doing. It's not about what your neighborhood's doing. It's also society. Our panel before talked about impressions and impact that go all the way back to transatlantic slave trade. What is the impact that all of that's having together? Collectively, through public health, there are different approaches that we take. We can take a primary prevention approach that is about making sure that we're working with people early and working with them to prevent some of the issues. But understanding there's complexity and there's race and racism that's involved in that. But also, what are we doing secondary? What about the individuals that were harmed, like Dr. Tyler mentioned, right? Secondary and tertiary. I work at a trauma center for the violence recovery program that actually focuses on secondary and tertiary prevention for those that have been harmed and how we can work around crisis intervention to have a trauma responsive, person-centered approach that help with their comprehensive recovery and their re-injury. So that's why public health is important. It has a historical implication, things that we talk about today in terms of life expectancy. The community that's predominantly black might be 20 years under a community that's predominantly white, right? Those same things exist. We cannot be in the business of blaming individuals. We need to look at the entire ecosystem. Thanks.
You know, the challenge of thinking about gun violence, and I'm speaking now about in the African American community, as a public health issue, it presumes that outside of the African American community, there's a public that's actually interested in the gun violence in black and brown communities. I don't think they are, right? I think that they're quite satisfied with what's going on with black people and brown people killing each other, to be perfectly blunt about it. And so they don't want gun laws. They don't, you know, they'll send some police down there occasionally and drag the bodies out, but at the end of the day, it's not a public health issue for them. And so the challenge is really in our community. This is one of these things that in our community, we have to solve the problem, right? We have to organize and solve this particular problem in our community. And it's historic, no question about it. This has been going on for generations, but we can't move forward. One of the things that I always think about, we're 52 years from 1965, right? 1965, historians kind of use as a landmark when we could go out in society and own a house, own a business, go to a school, go to college, go to a library, right? Prior to 1965, you couldn't even go to a library. So we're in this particular moment now where prior generations could not define the community that they wanted to live in. They didn't have that capacity to define that community that they want to live in. We're in that particular moment, and one of the problems that we have to solve is violence and gun violence in our community. There's an old law, it's called Gramsci's Law. Bad money drives good money out of a community. And what it means is when you got crime and violence, it drives money out, good business practices out of the community. So we're in this particular moment where we have a problem in our community that a lot of folks don't even want to give you drinking water. You want them to take a gun away from you, right? They're happy you got the gun, right? So when I think about this as a public health issue, I think of this as an endemic public health issue. This is something endemic to our community that we have to resolve, and we have to come together as a community and figure that one out.
Thank you. There were a couple of things mentioned. One, talking about public health approach and really looking at gun violence as a disease, understanding that it is a disease, that it's transferable, but also that, you know, it can be stopped, right? So talking about stopping the spread, finding out where is it coming from, stopping the spread, just like you would do with any other kind of infectious disease. And similar to infectious diseases like COVID-19, we saw a disproportionate impact on the Black community. And so, Dr. Puckering, I'd like you to talk, and you kind of were going there already, but talk more about why it's important that Black voices are central to this conversation.
So think a little bit about the disinformation that flows into our community that present these ideas to our young people, the use of guns, I mean, you turn on any television show, right? And to be a man is to carry a gun, is to you know, show that you can push back. So the challenges for our community is that it gets down to us defining reality for ourselves. We have a lot of smart people sitting here, up here at this podium. I think if we sat around the table together, we could sort this one out. But the problem is we also have to fight the external community, the disinformation that they want to push in our community. And that's where the policymakers are so incredibly important, because they've got to navigate around the idea the National Rifle Association wants everybody to have a gun, right? They don't care. The U.S. Supreme Court looks at New York and says, hey, we need to get rid of that law so that everybody running the subway can have a gun, right? Those are the kinds of problems that are incredibly difficult for us to solve, because that external environment is not going to support us. And that's why collectively we have to work together and find those resources that allow us to go into our community and really solve this problem.
Is it okay to add to that? No, absolutely. So this narrative that exists symbolically, if we go upstream, we also see that, yeah, there's this narrative around that we need to carry a gun, but there's evidence over multiple generations. You walk outside, there are empty lots. I'm in Chicago, right? So Chicago alone, we had the largest destruction of public housing in United States history happen in Chicago. What happens next? Your schools close. Who are the first parents that you who are the first adults that you interact with outside of your parents? They're your teachers. When you have bonds with that and your schools close, now you're taking away that, right? You're taking away the opportunity for men and women to connect, because you're breaking up the protective factors that exist at the community level, right? The ability for us to rap, to say, hey, that's a myth, dog. Like, listen, this is what you really need to do. When you break that up, and that's happening over multiple generations, what our youth find, and Dr. Taylor's doing specific work with men and women that are at the highest risk, focusing on those that feel like they got to carry a gun in order to be safe. They don't want to get caught out there lacking, right? And so also, systemically, what's being done to actually give justice? So there's justice not being served in terms of public infrastructure. Then when you're harmed, there's nothing that's being solved. So individuals feel like that they need to solve it themselves. So when it comes to the moderator asked a question about the messaging, it's important to actually have credible messengers, individuals that have not only been in through that interpersonal harm, but also the structural harm, because they have lived a life, they've made the changes, they've done that in what they're asking you to do, right? There has been so much symbolic disinvestment and actual disinvestment that who are you going to trust? Our institution, so the University of Chicago Medicine, I described the closing of Chicago public schools, I described the public housing, there's the disappearance of jobs. 1965, guess what happened? That's the civil rights movement. What was happening then? White flight, right? So instead of investing in social services, mental health services, we're investing in policing, right? So we double down, right? 50 years later, there is a 600% increase in incarcerations, right? But no evidence in terms of a decrease in crime. Crime goes up and down like a roller coaster. So the University of Chicago, for 30 years, did not have a level 1 trauma center, right? And thanks to activism from the community, they put pressure and our leaders got a level 1 trauma center. It was important for our leaders at the hospital to say, we also need to have a hospital-based violence intervention program to have, using the street outreach model, credible individuals that have been touched by that interpersonal harm, that structural harm, that can greet you to understand, hey, you know what? Without a doubt, we have unconditional, positive regard for you. We are not here to investigate why you got harmed. We're here to help you towards your path, right? And that is a step that's important, having credible individuals that are on the front lines to help with the resources as we're battling these external partners.
Well, first of all, I want to shout out Arnita Holloman for holding me down as I was coming from another panel. So give her a round of applause. I'm Greg Jackson. I'm the Executive Director for Community Justice Action Fund. And part of my intro is a question. I'm a survivor of gun violence. I was actually shot on 7th and O Street. And the bullet that hit me, the bullets that missed me hit the convention center. That's how close I was to this location when I was shot. But what was more traumatic than being shot was my experience in the hospital. I was met with 3 investigators and questioned. I couldn't see my family for over 14 hours. I was placed in the burn unit during my treatment. And so my question is, you know, what do you all think is the impact of victims of gun violence and those who are being exposed to gun violence, and what role does that play in this crisis? And what can be done in the health system to help protect and prevent those negative impacts on those who have been directly impacted beyond hospital-based intervention? What can we do in our healthcare system to address this crisis better?
Yeah, I think I could talk about that a little bit. First of all, it's very important to prevent or mitigate the impact of violence, particularly on children. As many of you know, experiencing violence as a child is what's known as an adverse childhood experience, or ACE, which is linked to physical, mental, and behavioral health challenges later in life. But if we can stop that cycle of violence, particularly for future generations, we really can prevent a lot of the trauma and the violence that we're seeing. So I think when we can support strategies like housing assistance programs and child care subsidies and earned income tax credits and really just livable wages that can help lift individuals and families out of poverty, we can have a pretty huge impact. In terms of some of the programs that we work with, we do partner with communities to implement. There's an Essentials for Childhood program that's funded through CDC, as well as PACE Data to Action, Preventing Adverse Childhood Experiences Data to Action. And those programs really do address the underlying conditions that contribute to violence, particularly those underlying economic conditions.
All right, so I'll speak to that next.
Jump in there.
All right, absolutely. So there's a great deal of harm caused by being a direct victim as well as witnessing violence. You know, especially when you live in communities where there's frequent shootings on a regular basis. Some of these neighborhoods are literally war zones, right? Literally, right? So there are groups of individuals who are shooting and killing each other with intent, right? And so if you're exposed to this level of violence, it has a major impact on you psychologically as well as physically. You know, so what I see is a great deal of traumatic stress as well as depression. And if you noticed, I didn't say post-traumatic stress. I said traumatic stress because it's not in the past, right? Well, it is in the past, but it's also in the present, and it's likely to be in the future, right? And so that has a magnified effect in terms of on a person psychologically, and certainly one of those effects is the impulse to be aggressive, right? And so it's, you know, violence begets more violence, particularly when a person cannot establish safety and protection from harm in the midst of these circumstances, right? And so that's one of the reasons why we place a great deal of emphasis on doing violence interruptions directly in the streets. So we're working with groups to establish peace agreements, non-aggression and peace agreements, so we can begin to move the community toward greater safety. We're working with individuals to help them move towards safety individually, as well as providing the level of treatment they need to recover from this ongoing exposure to trauma.
I got a question for Dr. Kozige here. What you've done a lot of work with youth specifically, and we'll hear on TV or policymakers, we just got to give jobs, give jobs, give jobs. Just curious to hear from your perspective, what type of opportunities do we truly need to give to our youth to help steer them away from a life of violent crime? And how have youth-based programs that you've worked with specifically been impactful?
Yeah, no, thank you. So the fundamental issue is always we need to pay attention to the root causes, right? Like fundamentally, like if we're not investing in those communities, right? If we don't have businesses, housing opportunities, then folks are focusing on their fundamental needs, right? However, with that being said, there's a legacy of great, strong programs from work that we did by surveying over 3,200 6th, 8th, 10th, and 12th graders across our great migration community in Chicago known as Bronzeville, right? As well as interviewing agencies, 48 agencies that provided youth programming, interviewing 400 residents across 20 census tracts in the Bronzeville community. What we found out is that there are a lot of programs that are in the community, but our youth don't know about the programs. The impact of violence has people hyper-localized where they are safe block by block, right? And so what we need to do is that we need to have an emphasis on upstream issues that address the structural factors that are driving why our communities look the way that they do. The basis of that is racism in terms of who had opportunities, how you use housing to build equity, who was excluded from that opportunity over generations, and how in just Chicago alone, the housing inequities that go back to the 50s and 60s account today for a $3 to $4 billion wealth gap between white Chicagoans and black Chicagoans. What individuals in Chicago, what we need to elevate is that 40% of the zip codes in Chicago are economically distressed, right? Economically distressed in terms of lack of businesses that are in the community, the lack of home ownerships, education levels that don't go beyond high school, right? If you look at New York City and Los Angeles in comparison, they're at 16 and 15% compared to Chicago, 40% of those zip codes. So we have to continue to go upstream. We need to rely on credible messengers to communicate what is actually available in the community, right? But also who can be trusted. So some folks are doing programs out of earnest, but they're not reaching the right people. It's one thing to do programs that are focused on kids that are in school, but what about the youth that have been, they're removed from school? Because not just because they just simply dropped out, they need to take care of their family. What are we doing to engage out-of-school youth as well? And so I really lean heavily on the relationships and collaboration with street outreach organizations, individuals that have lived that life. And in our program as well, we have individuals embedded in the emergency room who do crisis intervention, but we also have a staff of folks that are in outpatient clinic that work on establishing those resources. But it has to be patient-centered, person-centered. It's driven by what they need. Building trust takes a lot of time, and there's a lot to overcome in terms of what's happened. But bridging that gap between programs that exist is going to be very important. We were floored to hear how many programs existed, but our youth didn't know about them.
I got two more questions and then one for everybody. But next is coming back to you, Dr. Gervin. Can you share a little bit about, I think this is the first time in history we've had a CDC director speak out publicly and call this a public health crisis. And so y'all have become true leaders in the space. But I also know that you've done a lot of work around research and data, and just would love if you could give an overview of what research and data you've done, any obstacles you've seen, and what's to come from the CDC in this space.
Yeah, thank you for that question. Well, as I mentioned earlier, yeah, our primary focus really is around data collection, research, and then action, implementing what we learn into practice. A lot of the research that we've done is really around the risk and protective factors, as you've heard some of the panelists talk about. But we need to do more around understanding the implementation side of things. Like, for example, one program that may be implemented really well in Chicago, and I heard you talk about Cure Violence, I think the original program. We need to know whether that program works in Atlanta and in Houston and in different settings with other populations. So there's some more work to be done there. On the data side, one of our data systems is the NVDRS, National Violent Death Reporting System, which is a anonymous state-based system. We collect data from all 50 states, jurisdictions as well. But it helps us to understand the who, where, and how of violent deaths so that we can then inform our implementation. So the challenge with that data, though, is there's a lag. Those data are derived from coroner reports, medical examiner reports, and law enforcement investigations. So there can be a 9 to 18-month lag sometimes with the data. And so we're looking to emergency rooms right now. Syndromic surveillance data from emergency rooms is near real-time data that helps us to understand non-fatal injuries as well as fatal injuries so that we can then frame a prevention approach within those communities. So those are just two, and the program associated with that work is the FASTER program, firearm injury surveillance through emergency rooms. Currently, we fund 10 state health departments to get engaged in that work, but there's an opportunity to do much more in that space.
I got a follow-up for you because the next question I got to opt you out. But are there any big gaps in the data and research around gun violence, and what can we as an audience know about fighting for more research and data, or what can we advocate or push for or even fund?
Yep, gaps around, again, implementation science. We need to do much more evaluation. Some gaps. We know some programs that work, but again, different settings. When the settings change or a different population, we need to strengthen that area. I think mass shootings, police shootings, those are other areas that we're starting to explore through some of our research. I know there was an executive order that came out, I think in May of this year, around policing. And this administration is taking a really close look at police-involved shootings. And so there are some opportunities there as well.
All right, y'all. This is the big one. Y'all ready? This year, for the first time in 30 years, we saw the passage of the Bipartisan Safer Communities Act, the first bill in 30 years to address gun violence. But I think all of us know that that's not it, and that's not the pill for this disease that we see of violence. And you have two of the most amazing, outspoken, charismatic, and aggressive advocates in the House of Representatives on solutions to address gun violence. So my question to you is, what is one thing that you think will be important for them to work on that can help us address this crisis? And I'm going to start on the end here with you, Doctor.
I was going to say two, but...
You can drop two.
Okay. First of all, I pick up on the data, right? You can't fix what you can't measure. Right. And part of the problem is, what people don't realize is that Medicaid pays for 70% of the gun violence that's happening in the United States. It's real money, right? And Americans react to real money. And so part of what I would be doing is explaining to everyone what gun violence actually costs, not just to the individual, not just to the African American community. Those are taxpayer dollars that Medicaid pays for, and the disabilities that follow and the lost jobs, the financial implications of gun violence are absolutely tremendous. And I think we ought to pay attention to that because the American public will hear that. My number two is I would form a commission. I think it's time that we have a commission on the impact of gun violence in minority communities, bringing the best and the brightest together to build an action plan so that we can inform legislators about the policies that are needed. We have to think very, very carefully about that because what we're trying to do is break historic patterns, and they're not going to be broken easily. And I think we got a lot of smart people that we can bring together with good data and kind of sort this one out.
Before we go to the next answer, the latest report on the cost of gun violence produced by Everytown said that the national impact is $557 billion every year. And so you're onto something when we say that we're already paying for gun violence. And most of the bills that have been advocated for, the Break the Cycle of Violence Act, for example, which two of our champions are here, is simply asking for $6.5 billion. So a real small drop in the bucket based on what we're paying for already. So I'm glad you uplifted that.
Yeah, I am inspired by that act because since the pandemic began, we began to see a national mobilization around we cannot continue to invest in policing something that happens after the fact. We need to focus on prevention. We need to focus on community violence intervention. So that is absolutely spot on. And then when we're talking about like axiology, what are the things that people pay attention to? They pay attention to numbers. They pay attention to dollars. So spot on with that. I think for me at a granular level in terms of policy, I think in 1980, the Victims of Crime Act was passed. And one thing that's from that, working at a hospital-based violence intervention programs, is that there is a crime victim compensation program. And so as we're working to have a trauma-responsive, patient-centered approach towards comprehensive recovery, there is a huge barriers for our survivors of violence or our bereaved families that have lost individuals to violence to actually receiving compensation, right? In the state of Illinois alone, which is different than California, you are required to have a police report to actually get crime victim compensation, right? And so I think, the earlier panel inspired me going, we cannot be a historical society. We need to, first of all, think about the harms that have happened over generation, what has contributed to the economic wealth gap. And with this compensation, where's an opportunity for someone to pay for burial services? It's for someone to pay for mental health services. To have barriers like that where, you're just you're piling on the harm, just like your experience as a survivor of violence coming in and how you were received. What we need to do is focus on policies like crime victim compensation and get rid of those barriers immediately. There's funding that's been there for over 40 years. Right? Why are our black people not getting these funds, and they exist? So that policy-wide, that's something that I would like to see.
Quick note on that. So we are helping with the fair access to victims' compensation in New York, in the state of New York, with our partners at Common Justice. They found that 4% of gun violence victims were getting victims' compensation. 4%. And when I was shot, my bill when I came out the hospital was $20,000. Luckily, I was able to get victims' crime compensation funds, but imagine what economic hole that could spiral you into. And again, that's happening to 96% of New Yorkers, and I can't imagine how terrible it is across the country, so a good thing to lean on.
Yep, no, thank you. And I want to just quickly add, one way that we're addressing this through our program is that we are expanding to have medical legal partnerships within there, so we actually have lawyers that can focus on some of these health harm needs legally. And so, thank you.
Yeah, so I would start with saying we definitely need more research, right? But there is a solid research base now, particularly around community intervention work. I think about the work that's been done in the city of Los Angeles, who had just a tremendous turnaround, from over 1,300 murders in 1 year down to less than 300 for several years until the pandemic, and they crept up above 300, right? And so we have to learn the lessons from the work that they did, right? And so they have a significant amount of research around their gang violence, youth reduction whole project, right? We also have a growing research base in Chicago around the work of my organization, Chicago Cred, as well as other organizations in the city of Chicago doing similar work. We have to begin to understand the extent to which these practices may be successful in other areas, as the doctor mentioned, right? But along with that, I also would say, as we verify the efficacy of these strategies, we really need to build up the workforce, right? We need a much more, a larger workforce, more training, more development, particularly around best practices, to be able to go into the communities and do this work. If we think about the numbers of shootings and killings that take place in our communities, think about the numbers of family members and neighbors impacted by all of these shootings, right? And, what treatment have they received, right? What assistance have they received in connection with what the brother was speaking about earlier? So we need much more in those areas to combat this problem at the community level.
All right. I gave you a pass, but you can jump in here.
No, I got to jump in. Yeah, I think I would encourage decision makers to take a multi-sector approach, encourage multiple sectors to come to the table. Public health cannot do it alone. We need public health with justice, with education, with housing. We need everyone at the table pulling in the same direction to really address gun violence and violence in general within the community.
Appreciate that. I'm going to open it up and see if folks have any questions from the audience. There's a microphone over there, or if you're close enough, you can yell at my way and I'll repeat it. But yes, please just raise your hand or jump over to the mic. If not, I got one more. Okay. Yes, we got you.
Hi, so I don't even have a question. I just have a comment.
Okay.
I just want to say thank you. It feels so good to see this panel of black men having this conversation. It really warms my heart. I've worked in every prison in the state of Delaware, and when you talk to people who are incarcerated and you begin to peel back those layers, it takes you right back to that child whose social determinants of health needs weren't met, that child who experienced adverse childhood experiences, that child who wasn't taught how to effectively utilize their coping mechanisms. And then what happens is they end up in the juvenile justice system, and some go straight to the adult justice system, and we're still not doing the work. We're not addressing it holistically. We're not providing cognitive behavioral therapy. We're not setting them up with a mentor. We're sending them right back out to the community, and then we're just giving them the pass right into the adult justice system. So I want to say thank you for having this conversation. This is a public health crisis, and it's going to take all of us to really get onto the forefront of this, because so many of our kids we talk about second chances, so many of our kids have never even had a first chance. They've never even had a first chance. So we got to do the work. So thank you for starting this conversation, and I'm so excited to carry this charge in Delaware.
Awesome, man. Thank you. And thank you. Thank you for all your leadership and hard work. If we don't have any more questions, yes, sir. The question is, what role does culture play, or do we think culture is playing a major role in this crisis?
Yeah. Is it okay?
Yeah.
Thank you. So when the sisters were up on the panel and they were raising some of the themes that are connected to slavery, I'm inspired. There's a leader, Dr. Joy DeGruy, wrote a book, Post-Traumatic Slave Syndrome. And so some of the themes that are impacting us are passed down because of the structure, as the sister talked about, what our bodies meant to the society in terms of what we were able to earn. And so in terms of how the economic system that was driven by slave-based economies, right? And so part of that has been in response to always being on defense. Always being on defense to protect, always being on defense to against these systems that continue to disrupt us The public health approach at the community level, the core things at the community level, protective factors, are our ability to support each other, our ability to have beliefs about how we want our community to look, and then our ability to act on that informally, not with police, but informal, what we describe as informal social control. The systems that have been in place, from Jim Crow segregation to redlining to restricted covenants to urban renewal to the hyper-incarceration to, as I described in Chicago as well, destruction of the massive disinvestment, continue to disrupt those systems that keep communities safe. So bigger than cultural, and I'm not sure how you frame, like the question, the structural mechanisms we really need to continue to analyze, because that is what is making our community unsafe. It is these structural mechanisms, in my opinion.
Yeah, I just want to leap in, because what we also have to understand, slavery and Jim Crow were very violent societies, right? In the slave world, the rule was make them stand and fair. That's how you maintain slaves. You had to make them stand and fair. You have to kill the aspirations that bubble up in communities where people want to do better, but you don't want them to do better. And what ends up happening is that black lives get devalued, right? They're not valuable at all except in the marketplace. And that seeps into our community, where we lose a sense of value about who we are, what we want to aspire to. So now we're in this very unique moment. This is only 13% of our history in American history, right? Most of our time in this country, 87% of the time in America, we lived in a very violent society. And so what we're trying to do now is we're trying to create sustainable, healthy communities. And part of that, getting to that sustainability, is that we've got to deal with the violence that's inside our community, that was bred inside our community. That's a very, very difficult thing to change. Culture is very, very hard to break, but that's the mission. That's the work at hand. And we've got very, very smart people, and we've got an opportunity to do it where generations before us didn't have that opportunity. And so this is really a fabulous moment to bring together very, very smart people to try to do something that's incredibly difficult to do, which is to break cultural patterns.
Can I jump in there? Yeah, so, and I'm not sure exactly what you meant by culture, but my interpretation of that is this. The individuals who are involved with violence on a day-to-day basis, right? Their drive to change is often accelerated by getting some self-knowledge, getting some understanding of who they really are, right? Getting in touch with our best values as a community, understanding and expanding their awareness of the broader picture that these gentlemen speak about. That is often the drive to do something different. Then I want to say this. Part of what is best about us as a people is the extent to which we are connected to each other, right? This is really the heart of our culture, right? It's us being one, unified, together as a whole, right? And so using that as a means to help those individuals change is a key part of practices that are most effective, right? Bringing them into situations where they can be part of a larger group of men and women, right, who are focused on life and living in spirit and positivity and community building and self-determination in our overall development is a key aspect and key component of them to change.
Yeah, and I want to just be a little raw with it too. You know, I'm slightly younger than some of the panelists. But, you know, I grew up in a world where everyone I looked up to was shot and killed. Martin Luther King, shot and killed. Malcolm X, shot and killed. The first rap verse I ever learned was Only You, 112, and Biggie Smalls, Biggie, shot and killed. And I was looking at my iPad, half the albums that I listened to are people who've been shot and killed. And for my generation at least, and I imagine some of the younger generations, it's not that gun violence is this big scary thing. It feels almost inevitable for us. And the only way to escape it is to become super rich like a Jay-Z or LeBron James and shield yourself from it. But when you watch young Dolph get shot getting cookies, you know, P&B Rock, who is he sings about love, R&B singer really, shot getting waffles and chicken with his partner, right? Like, we're watching our peers and people that we look up to or celebrate or enjoy getting shot down, just doing very basic functions. And that is traumatic. I think what also is important about our culture is a reflection of reality. And in so many of our communities, that is a reality. I had some friends over yesterday, and they wanted to watch a movie. We put on Menace to Society. And, you know, that's a movie that we all know. Oh, Menace to Society, yeah. But if you really watch it, that's a horror movie. You know, it's a horror movie to watch those young men go through all that trauma and go through those very savage and violent situations and still trying to find some joy in their day-to-day life. And so I think the culture is something that we should pay attention to, not always demonize, but look to it for solutions. You know, one rapper just released an album a few months ago, Mozzie, and the name of his album is literally Untreated Trauma. That's the name of the album. And if that's not a call for help, I don't know what is. And if you look at what's happening, a lot of the folks who are suffering, they're crying out for help through their expression. And that is through music, that is through television, that is through entertainment. But yet we turn around and demonize, we turn around and scan those lyrics and try to lock someone up. But we don't think about, okay, what's happening here and how do we treat this and who's their family and who's their younger siblings. So I think culture does play a big role, but for me, I see it as almost a cheat code. It's a way for you to glance into what's happening without having to physically be there. And we should all soak that up and think about solutions to address the crisis our folks are going through. All right, if we don't have any more questions, we're going to take, we have one more over there. I'm sorry, I can't see the mic too well.
I know, you can't see me. Hi there, I'm Congresswoman Kelly, Senior Health Policy Advisor, and so thank you all so much for the panel and all the wonderful things you've been kind of talking about and sharing your personal experience as well, Greg. My question was about the role of women in addressing gun violence. I wanted to hear you all speak a little bit about violence, women against women, and you know what that plays. I know people often think of men, you know, violence black men against black men, and also how including them in interventions can make those interventions more effective, and how like that holistic whole family approach. You know, women are partners, their mothers, their aunts. Like how when you include them, how does that make the intervention more effective?
I definitely have thoughts on this, but jump in there, Fred.
Yeah, that's very important. And let me start by saying, you know, so we have street outreach workers. Many of them are women, right? Some of the best ones are sisters out there on the streets, right? They're connected with the people in the communities who are involved. They have the relationships to be able to get the work done to help us move forward, right? My whole team of clinicians is mostly women. We also have women who work for us as life coaches, very integral part of what we do. We have several program sites, buildings that we work out of in the city of Chicago. Every one of our program managers is a woman, right? As we do our work, it's very important that we connect with the mothers, with the sisters, with the mothers of the children, of the men that we work with. We also have a women's program. People don't understand that there are young women who are also shooting people, right, as well as being shot. And, of course, they have the double problem of domestic violence and on top of the street violence. So they go hand in hand. And so our work is involving women is very important on all of those levels.
I would just say, go ahead.
Oh, no, you know, I'm in this hospital-based space, and like Dr. Taylor said, most of our staff are indeed women, and they're excellent, and they're driving this work. Before I came to the hospital-based space, I was doing prevention work, families in school, also evaluating cure violence was part of it. And my mentor told me that I need to, before I start this job, I should read Hood Feminism. And what's very important is to really understand the nuance behind women and their leadership, that in this work as well around violence prevention, how are they being harmed, what's invisible in terms of we're focusing on the direct victims, which in many cases in a city like Chicago, you're talking about at just our hospital, 78% of them are men, right? 85% of them are black men, right? Like, so 85% of them are black. And so with that, what about the invisible nature? What about the partners, as you described, all the different roles you described. What are we doing for their mental health as well? So foregrounding that, hood feminism, I think, gives a great account theme by theme, and so that's something that is inspiring us.
I also will say there's a huge crisis that's happening, and it's not being talked about enough. And I think we all have a responsibility in this issue. But right now, there's over 100,000 black women and girls that either are murdered or go missing every year. And just because we don't know it's a result of domestic violence, we don't know it's a result of community violence or interpersonal violence, doesn't mean that it's not important. And I think if we can discover those stories, learn those stories and learn about what happened, then we'll start to see the real picture of violence in America. It's not just black men and boys. And that's why I'm really excited that there's the Protect Black Women and Girls Act, sponsored by Representative Robin Kelly, that is really pushing to do some research and put pressure on government agencies to dig into this crisis. Because right now it's seen as a policing response, an investigation, a missing person response, but no one's looking at the entire epidemic and what needs to be done. The last thing I will share, yes.
Co-chair and co-founder of the Caucus on Black Women and Girls, which, of course, my twin sister, colleague, friend is a part of also. But we've had a couple of sessions, one in D.C. We started on missing girls because it was such a problem with not talking about black women and girls, and we also just had it in Chicago too. So we actually had Lori Lightfoot was on, and she actually spoke to one of the people whose relative was still missing to try to get that going. So we actually had real people that had real relatives missing. So we're trying, to stay on top of all these issues. It's just so many of them. But thank all of you so much.
Thank you for your leadership. Let's see, I missed any more questions? I will say one more quick piece on that. When we were doing work in the D.C. Office of Neighborhood Safety, and we were working with the at-risk youth and young men, very similar to Chicago Parade. I think we learned a lot of lessons from y'all. The first thing we noticed is that it was women dropping them off, right? It was women picking them up. Their entire world revolved around the women in their lives. And so even if they're not specifically the at-risk or specifically the one harmed, they play a huge role in the direction of those young men and individuals. And whether it's a mother, a partner, a wife, a daughter, that voice is probably the most influential voice when working with those who are most at risk. And so we knew immediately that we had to get to the entire family, and I think that's a lesson that we should continue to spread. All right, I think we're a little bit over time. So I wanted to see if there was, we're going to lightning rod. Let's go. If you have one more big thing that you would like the audience or others to learn or know or take away from the day, please share it. And then we're going to say farewell with our members of Congress.
I'm just going to reinforce that we need a national commission to really take this problem on. I think we can't do this alone, and so I think we have to come together.
No, indeed. And there are folks coming together now. There's a Black and Brown Gun Violence Prevention national group that's led by Shani Bugs that is collaborating and making sure that they're foregrounding Black and Brown researchers. Related to research, the thing that I would add is around implementation. So there are dollars that are coming out, but we cannot have the dollars that are coming out and have these unrealistic expectations in terms of impact. We need, with implementation science, we need to double down on building the capacity for these organizations. A lot of the funding that's coming in is municipal-based funding that already has a rigorous reporting system that pulls community-based CBIs from their ability to do the work. And so we need to also fund money so they can build their capacity around that, including with understanding that building evidence takes steps. Right? And so you just don't go from having a program to a randomized control trial, right? You need to have pre-implementation steps. Think about impact outcomes as well. So dollars need to go towards capacity, not only for data, but also for the functioning of that organization.
I would say our families need a lot more support. So we think about the individuals who are involved with violence. This is really a multi-generational family issue in terms of exposure to trauma. right? And so a lot of times the family is typically a mother or a grandmother taking care of multiple children or grandchildren, sometimes adults in the household, right? And they're trying to carry the ball all by themselves without a lot of support and assistance, right? And so we need a lot more intervention around supporting families in general and the mothers who are often at the heart of those families.
Primary prevention. Primary prevention is the key. We need to be much further upstream. If we do that work further upstream, we really can stop violence before it occurs. The other part of that is embracing a comprehensive approach to violence prevention. We have some great resources in our technical package. We have a comprehensive approach to youth violence prevention technical package. We talked earlier about the vital signs that came out this summer on firearm violence. And so I encourage folks to check out those resources.
And my last word is that despite how overwhelming this issue can feel and seem and be to a lot of families, there are real solutions that exist. And there are many people, many of which on this stage, thousands of organizations across the country that are working day and night to address violence in different ways. But they need our support. They need our political support. They need our financial support. They need our emotional support. And it really requires all of us coming together to support them and also support the victims and survivors to implement what we know already works. And in the words of my good friend, Corey Winfield, he's the site director for Safe Streets Baltimore. He always says, you know, his job is to make sure that when you look your loved one or your family member or friend in the eye and say, see you soon, his job is to make sure you actually see them soon. And so in his words, I would like to say, thank you, and we will see you soon. And I will pass it over to Representative.
Thank you, Greg. One more time for this panel. Again, substance, phenomenal. You guys can depart the stage. We're going to have the next group come up for our next session. I will just say that I literally have written all over this paper, all of the different suggestions, words, and I guess as we move into the next panel, I also want to highlight for Robin Kelly, Joe Neguse, Stephen Horsford, Lucy McBath, members of the Congressional Black Caucus who have worked tirelessly and just last week passed the Break the Cycle of Violence bill in the House. And so I want to thank our colleagues as well for that work. As the next panel comes and takes position, I also want to take a minute to say one of the things that I hope we also don't lose in this work is our own self-care. And so I don't know, you know, as I listen and I'm taking down these notes and I'm thinking about the affected families and communities and our own families and communities, my heart starts beating fast. And so I hope that you will, like, as they come up, we're going to take a breath together. We're going to take maybe 2 or 3. And I'm just going to say, breathe in and breathe out. Can we do that? You at home, too, because I know you're feeling it, too. Self-care. On the count of 3, 1, 2, 3. In. Release. In. Release. One more time. In. Release. Yeah, that feels good. That feels good. And it is a perfect segue for the next panel. Those of you who are just joining us, we had an incredible panel. The first panel where we talked about abortion care, but also reproductive justice. A second panel where we talked about gun violence as a public health issue. And in this one, we welcome those who've stayed throughout. Our final panel is successful strategies for addressing substance use disorder in Black communities. And it will be moderated by Karen Howard. Karen currently serves as Director of Policy and Advocacy for Mental Health America and has 13 years experience in legislative and political affairs and advocacy. She educates and persuades federal and state policymakers to act on a wide range of issues that impact individuals with mental health conditions, including health care, education, criminal justice, and housing. And she facilitates relationships between state and local MHA affiliates and their federal and state public officials. Ladies, gentlemen, individuals, thank you and welcome to our next panel.
Thank you so much, Congresswoman. Hi, everyone. It's really a pleasure to be here today. Thank you so much, Congresswoman Blunt Rochester and Congresswoman Kelly, for allowing MHA to help host this panel. Happy Suicide Prevention and Recovery Month, the month of September. I am Karen Howard, the Director of Policy and Advocacy at a consumer advocacy organization that's been fighting for people with mental health conditions to live out in the open without shame since 1909, and we have affiliates in over 40 states. My pronouns are she, hers, and MHA's largest program is an online confidential screening program that offers clinically validated screenings online and provides information they can use to determine next steps. In 2021, over 64,000 people in the U.S. took the substance use disorder screening for use for different substances, including the big three: alcohol, tobacco, marijuana, as well as others, including heroin. 1 in 5 of these people also reported suicidality, including intentional self-harm and cutting. SAMHSA, the Substance Abuse and Mental Health Administration's National Survey on Drug Use and Health in 2020, indicated that 2/3 of people with substance use disorders had co-occurring mental health conditions. And the Commonwealth Fund's 2016 survey showed all of high-income countries, out of all high-income countries, the U.S. has some of the worst mental health-related outcomes, including the highest suicide rate and the second highest drug-related death rate. Just as we see Black women bearing the weight of abysmal maternal mortality rates in the U.S., Black men are dying of overdose at nearly 3 times any other demographic. Meanwhile, restrictive rules in the states are putting evidence-based medication-assisted treatment and harm reduction practices out of reach for many. When we discuss what successful recovery from substance use disorders looks like for Black families and individuals, it means overcoming more barriers than others because of structural and institutional racism, impacting not only our identity, attitudes, and sense of belonging and connectedness, but also the workforce we must engage, the facilities we go to, and the neighborhoods in which we live that supply the food, transportation, and housing needs we have, as well as education and understanding. However, as it is one of the principles of peer support, and also as the historical saying goes, we've got to keep hope alive. Hope is that principle. We appreciate Congresswoman Kelly's introduction of the Health Equity and Accountability Act comprehensive legislation in the 117th Congress that would begin to address many of these problems in our racialized society and more. And we appreciate the current administration has created a unity agenda that includes a comprehensive approach to address substance use disorders and inequity. The Departments of Health and Human Services, Centers for Medicare and Medicaid, and other agencies are starting to give attention to integrated care, social determinants of health, the allied health professionals workforce, such as peer specialists, but more must be done, like expanding the workforce with racially diverse individuals and investing in housing-first models, and it must be done quickly. I will now open up this panel to our esteemed speakers, and I will do a lot less of the talking. We'll start with spoken word from Joseph Green of Springfield, Virginia, a certified peer recovery specialist trainer, a disruptor, and the CEO of LMS Voice. We will then ask questions of each of today's panelists and end with a live Q&A audience session. So have your questions ready and written down. Please note that part of my role as a moderator is to ensure we stay on time, so I will remind folks to wrap up their points and questions to allow input from everyone. Joining us today, we have Tia Dole, PhD, who's Executive Director of the Steve Fund and a licensed clinical psychologist and a longtime advocate for rights of youth of color. The STEVE Fund is a national organization whose aim is to support the health and emotional well-being of people of color. We also have Ms. Kenyatta Cathay, licensed clinical professional counselor, certified drug and alcohol counselor, and chief clinical officer at the Haymarket Center, the largest not-for-profit community-based adult detoxification, residential, and outpatient substance use treatment facility in Chicago, Illinois. Finally, we have Dr. Derek Robinson, an emergency medicine physician, as well as VP and Chief Medical Officer for Blue Cross Blue Shield of Illinois. In his role, Dr. Robinson is responsible for care management operations, clinical leadership, and strategic oversight in providing high-value healthcare to more than 8 million members. Joseph, I'd love for you to take it away from here.
Y'all can clap. Oh, look at all these beautiful people. Awesome. My name is Joseph Green. I am a black man in recovery, and this poem I'm going to do is dedicated to my father, who is also a black man in recovery, and we will get into it as we share further. But my art is one of the ways I advocate for us. It's called Life is Short. In the hospital bed, I helped him turn so the medication could spread more evenly. His eyes welled and cracked like fortune cookies. The piece of paper inside read, "Life is short, but being alive is the longest thing you will ever do. Proceed accordingly." If I'd attempted this homage to my father 20 years ago, it probably would have consisted more of those intangibles that drove me away. Hate and blame, more than just mere symptoms of childhood angst, but the language I learned to express how my father's absence from my formative years made me feel. You see, I once considered my father's DNA to be a cancer in me. Understanding the helix to be doubled, I never dreamed of losing myself completely, only half. A man now, I realize my thinking was the cancer. Forgiveness is medication. I'm still waiting for it to spread evenly. Always with the wrong bottle in hand from birth, my father showed me the image of addict. It looked something like a court jester juggling knives. One blade for family, one blade for work, one for the military that never treated him as equal, another for the father that died when he was 10, another for the mother that was never the same, all the while spiraling down towards the greatest come-to-Jesus moment ever. 16-year-old son in the back seat, his wife picks him up from jail after his second DUI. My father has been in recovery now for over 30 years. My father's poison was alcohol. Mine was cocaine. They say parents want children to grow up, achieve feats greater than their own. I don't believe this is what they had in mind. I spent a lifetime scared of mirrors for having his image projected back on me. I saw the new likeness at the bottom of empty whiskey bottles and clear plastic baggies. I mainlined hate and blame until I became so high I had nowhere to go. Rock bottom in the sky. I landed in my father's arms. Through falling, I've come to realize that just as he did not, I did not ask for this predilection towards addiction. That hate and blame are just new ways to get high for those of us not willing to change. And that which took him half a lifetime only took me 10 years because he has shown me what recovery looks like, what redemption looks like, what a life no longer lived in regret looks like. I refuse to be another son too scared of forgiving his father because he was too cowardly to forgive himself. Racing down Route 95, stopped by a cop for going 95, exclaiming out of the window of my car that like all men, my father is dying. And like most men, I never told him I understood. Never told him I forgive him. Never said, I realized one of those blades you juggled had love for family inscribed in it. And though I realize neither side of this reflection will ever be perfect, I am no longer scared of mirrors because life is short, but being alive is the longest thing you will ever do. Proceed accordingly. Thank you.
Hello. I had the pleasure of meeting Joseph Green at SAMHSA's Office of Recovery meeting, and one of the things that came out of that meeting is that SAMHSA's Office of Recovery actually is not in statute. It is a part of this administration's intention to elevate the voices of people with lived experience. So certainly for policymakers interested in making changes, we can suggest that putting the voice of people with lived experience in statute and making sure that regardless of who is at the helm of the administration, we have the voices of people in recovery. That's certainly an important point. I'd like to turn it over to all of our panelists now, and starting with Dr. Tia Dole of Steve Fund. Can you please share with us an overview of the current state of the substance use disorder crisis among the Black community in particular, and then how youth of color are being impacted?
So that was a tall order. When I saw that question, I was like, okay. And, one of the things I was thinking in preparing for this, because I actually thought my fellow panelists might do a better job. One of the things that when we think about the crisis of substance use and misuse among the Black community is that the statistics are confusing. And I think you started out talking about what are the statistics saying? So if you look at Black folks compared to other populations, it looks like we're doing relatively well. Our rates of using things like opioids is lower. And so you're like, well, why is this a crisis? And the reason why, from my perspective, it's a crisis is lack of access to services, lack of insurance, stigma. And I will add in, this is my own personal opinion, is that the crisis of marijuana use is something that we actually don't talk about enough because, we can talk about opioid use. It's really scary to think about young people using opioids. But from my perspective, the crisis of marijuana use, misuse, overuse, and use as essentially a benzodiazepine, they're using it for anxiety and depression, is the unspoken crisis in the Black community because it is so normalized. I'm sure half the people in here. So I'll say that the crisis is misleading by numerically, right, in terms of that. But when you add in the intersection of mental health and the comorbid mental health disorders with substance use, that is where you start to see a bump up of suicidal thoughts, suicidal behaviors, completed suicides, and it's that intersection with mental health where we're seeing terrifying rates of overdose deaths and suicide. And so I'll sum up there that it's almost like a silent crisis because I think the information that we have feels confusing and misleading. And I'll say from young people actually aren't turning to opioids in the same way, young Black people, but they are turning to marijuana. It's something that scares me as a clinician. Mostly, I started my career in early psychosis, and when you have prodrome, what used to be called prodrome and now ultra high risk for psychosis, as our ER doctor could say, if you smoke marijuana, it can actually push you over the edge into psychosis. And so the drugs that we are promoting and selling legally actually are really harmful to our young people.
Thank you so much. And you're reminding me that there really were kind of three different opioid epidemics. You had your prescription drugs, you have your heroin, and now we have the fentanyl. So, and oftentimes marijuana is considered a gateway drug or a drug to enter. However, they can oftentimes be used simultaneously.
Well, and realistically speaking, because it is so normalized now, the impact just alone of marijuana on motivation, on mood, it can't. So you can mix it with something, and of course it's terrifying and can be life-changing in a negative way. But marijuana itself is dangerous.
Thank you so much. I'll turn it over to Mr. Green. Would you please share your personal story with the audience and highlight themes in your road to recovery that can inform the discussion today? Also, would you take some time to describe your role as a peer support specialist trainer or peer support recovery trainer for those who aren't sure what a peer recovery specialist is?
Yeah. First of all, hello, everybody. It's an honor and pleasure to be here talking about something that hopefully will lead to making the world a better place and saving some lives. The peer specialist role is defined, and it doesn't just exist in substance use disorder, right? It exists in many places, and the idea or the concept behind it is that someone with lived experience has a better chance of connecting with someone who is in crisis because they have been there before. And this research on peer-to-peer is not something that is just for this space. It's something that we see everywhere. Peers listen to peers because there is a sense of authenticity. And when you're in your most vulnerable moment, it is really a pleasure. Nah, that's not the right word. It's really necessary to have somebody there whose function isn't just to save your life, right? So if we have a peer specialist in an emergency room, the job is to sort of like carry them through the process so that they know that they're not alone, because doctors are there to do what doctors do and nurses are there to do what nurses do. And it's an emergency room and it needs to happen quickly. So to have that person there as a point of contact allows that person who is in need to hold on to a bit of their humanity. And so we go through trainings, we learned how to coach, we learned how to get people into different services, we learned how to make relationships with the services in our town. It's very close to what you would think of as a community health worker, but specifically trained to do this thing because they have a lived experience in this thing. And y'all, I'm sure y'all work with these folks too, so feel free to elaborate. And because I said so much about that, I'm going to try to say pequeño about my life story. I did not do any drugs or alcohol as a youth, but I was raised in a household where alcohol, anyway, was used as a cure-all. Hard day at work, celebration, death, everything. This is what alcohol was its purpose. And so I was the president of the Youth Alcohol Drug Abuse Prevention Project, and I therefore left my house thinking that people who did drugs and alcohol were, to a point of addiction, were bad, and that they were making bad choices, and that it was a moral problem as opposed to a medical one. And when I found out that my father was an alcoholic when I was 16, it kind of destroyed our relationship. And so the things that need to be, I think, brought into this conversation from my story is the fact that my father's father died when he was 10, and he died, he was in a car accident in West Virginia, and they took him to the Black Hospital. And the Black Hospital was way out of the way, and he developed some sort of heart problem that took his life a couple of years later, right? So you have a generation of people raised by a generation of people that don't trust the medical system. And by extension, it's not always the absence of services, it's the lack of desire to even go into services, especially when you haven't been culturally taught that drugs and alcohol aren't the only way to deal with the problems that you see in front of you. I don't have a job, life is bad. My parents are broken up, life is bad. My friends, I have to go from here to here to get to school, and I see all of these negative things from here to here to get to school, and I don't want to feel this. And so I'm going to smoke weed, and I have access to it, and Jay-Z sells it, so like how bad can it be? And so there's a lack of culture change and a lack of conversation with the older generation about building trust and the younger generation about who they trust. And I think that should be part of the conversation.
Thank you so much. I thought of a couple of different themes there, including how peer supporters are helpful in other spaces like diabetes and cancer diagnosis, and then also that there's been a lack of kind of reconciliation. And while Black Americans were expected to take the vaccine for COVID at the same rate as whites, there really was still a lot of mistrust because of previous experimentation or poor care and intentional poor care. So there really needs to be kind of a reconciliation, I think.
Can I add something about a peer support?
Sure.
I think what, you had mentioned that it was someone who isn't trying to save the individual's life. I think it goes beyond that because, clinicians aren't perfect. And I think that the peer support creates a non-judgmental space that isn't always present with clinicians. We make the assumption that when you go to get a treatment, that you are going to have a skilled clinician who has experience with substance abuse, and I'm sure we'll get into it, but most clinicians aren't actually particularly skilled with substance use or misuse. And so I do think peer support is really, really essential, especially when we're talking about capacity and finding clinicians to see, to see people. They provide an essential service to folks who are seeking treatment because they don't have to explain themselves to someone who has no idea what they're talking about. They do intellectually, but that connection is really essential. So it's not just about you're not trying to save them. It's actually you see them.
As they are.
May I
Yes.
say something?
Yeah, I'm sorry if I indicated that was just their purpose was not to save their life, but I was saying there's an urgency of the people who are there in the emergency room that's what the goal is to keep the life going, and then there's the person that holds the hand. There's the person that translates. It's the person that understands that you probably, even as someone who is in active use, don't have the language that the clinician is using to explain what's happening to your body. And
Right.
I can put that into language that you can understand. So I think we're saying the same thing.
And Ms. Cathay, I was going to go to you next because you work directly with folks with SUD.
But before I start, can I mention something about peer support? Peer support has always been a fundamental with substance use, dating back to 12-step. It started with 12-step. These are individuals with shared problems and shared goals. And what they're trying to do is help this person reach the goal of recovery. It started with substance use disorder, and now it has moved, and now it's titled peers. But it's always been there in the substance use community.
Thank you so much. You work directly with people in treatment. Based on your experience, what strategies, interventions, and services have you seen work best? And are there lessons learned from flexibilities that Haymarket applied during COVID-19, in particular, that could expand treatment and recovery for the long term?
That's a lot. Okay. But let's start by saying, again, my name is Kenyatta Cathay. I am the Chief Clinical Officer at Haymarket Center. We are the largest single-standing substance use and behavioral health care organization in Chicago. We serve about 12,000 clients a year. 90% of the clients that we serve meet the federal definition of homelessness. 60% are African American, ages 26 to 49. Age of first use of any drug was before 14, and that's worth mentioning because it speaks to the severity and chronicity of the patients that we serve in a relapsing condition that is substance use disorder. 80% of the clients that we serve also have a co-occurring mental health condition that's been undiagnosed and untreated. And many of the patients that come into Haymarket have asthma, diabetes, high blood pressure, seizure disorder, and obesity. And our primary strategy is to treat all three conditions simultaneously. We would treat the mental health disorder, the substance use disorder, and the physical health disorder all at the same time, because we understand that if you fail to treat one, there will be a relapse to the other untreated condition. Now, as far as intervention goes, we believe that the greatest intervention for a person with substance use disorder is access to care. 3 years ago, we went open access, meaning that a person who seeks treatment can receive treatment at the time they request it. 365 days a year, 24 hours a day, 7 days a week, you can get treatment. There is no appointment necessary, just walk in. We have 19 evidence-based interventions that's been tested and validated on the treatment of African Americans. And primarily, we focus a lot on treating the family. We will treat the entire family. We believe that any person that's connected to the person seeking services contributes to this person's long-term recovery, because addiction can be a silent disorder. The family may not even realize how fractured they are until you start to treat the entire unit. We also move towards having medication-assisted recovery at all levels of care. We will do the induction, the stabilization, and the maintenance, regardless of your ability to pay. Now, thinking back on COVID, Disruption in care, stress, and isolation. Any of those factors can be a contributor to relapse or an overdose. And this is something that 100% of the patients experienced during the time of COVID. They encountered disruption in care, stress, and isolation from being unsuitably housed or showing up for care and realizing that the place that they would typically receive care is not even available to them at this time. So what we did was we moved towards a low barrier approach to a person receiving care. We looked to the minimum amount of information necessary to connect a person to treatment, and we moved towards telepsychiatry, telehealth, and telecounseling, understanding what we didn't know at the time is that many people, disenfranchised individuals, didn't have a data plan large enough for individual and group services. So what we had to do was set up these things called Zoom rooms where a person can come in and meet with their counselor, meet with their psychiatrist in an isolated space. And for those that were in a community, we worked with our state agency to figure out, again, low barrier ways to provide counseling services, doing it in a community, meeting outside, meeting a person at their car while the counselor was standing on the curb, just so that we can ensure that access remained available to our persons with substance use disorders.
Wow, that's really a lot of changes that you made to address the whole kind of whole health needs of a person. With the lack of kind of broadband, did you all take advantage of some of first of all, I want to talk about financing. So maybe we'll let Dr. Robinson speak and then come back, but I definitely want to hit on how you were able to finance some of that. Was it through Medicaid, Medicare, private, and all of that? But I'd love to ask Dr. Robinson a question first. What role can insurers play in increasing access to behavioral health care for communities of color? And how can SUD and behavioral health be more generally integrated into primary care?
Great. Thank you so much for the question. Again, my name is Jarek Robinson. I'm the Chief Medical Officer, Vice President of Blue Cross and Blue Shield of Illinois, and also a practicing emergency medicine physician. I'll take the second half of your question first. I think our primary care providers play a very important role in protecting the health care of our communities, and certainly our heads and bodies don't operate separately. They're part of the same unit. And while there's certainly a role for psychiatrists and psychologists and individuals who have specialization in addiction treatment, our primary care providers do play an important role in helping manage behavioral health conditions, including opioid use disorder. Now, one of the challenges that we see is that there is some stigma around opioid use disorder and addiction, right? And even amongst providers that decide to go down that journey, maybe take advantage of some of the waivers that have been granted, still have some hesitation around, do they need additional staffing in their offices? Do they have the appropriate referral networks? Do they have a easy-to-follow treatment flow chart or algorithm that can help them with decision-making? And so I think there are some opportunities for us, not only with primary care providers that are practicing currently, but also if we look at the educational pathway. So there are things that we can do to help make this part of the foundational knowledge for medical students as they're going through training, or in residency, or for our mid-level providers as they're going through their respective training, so that as they get to the point where they're moving out into practice on their own, they're less hesitant with regard to providing medication-assisted therapy. On a health plan side, health equity has been very important to us at Blue Cross and Blue Shield of Illinois. We've, I think, been an industry leader in that particular space. When we began to look at this issue around opioid use disorder across Illinois and in Chicago, we certainly were responsive to the data that we've seen, right? So we know that in Chicago, there are 3 times as many EMS calls for opioid overdose calls in the black community versus in the white community. That's a huge issue. And so we began to look at our claims data. So we went through our claims data on the medical side to see where are the top 10 zip codes where we're seeing patients that are either being admitted to the hospital or visiting the ER with an opioid use disorder-related condition. And then we went back and looked at the pharmacy data to see, okay, well, who are the prescribers in these top 10 areas, and what are they prescribing? And one of the things that we found was interest in distribution of who's getting buprenorphine versus who's being prescribed methadone. And we saw that the majority of our methadone claims were coming from individuals who lived on the south side of Chicago or on the west side of Chicago. And those individuals who had claims for buprenorphine were coming primarily from the north side of Chicago or the near west side of Chicago. There's an interesting overlap in terms of where you see the EMS calls, where you see the high economic hardship. Chicago is a racially segregated city, like many cities across America. And so you see that correlation between, race and income and coverage and access. And that's a significant issue. So one of the things that we set out to do was to reach out to our primary care providers in those top 10 zip codes to make them aware that this was an issue that we were seeing, to provide additional training to help with the level of comfort with regard to becoming a prescriber of buprenorphine, and then also making available a financial incentive for folks to come and do the training. And we then deployed a survey so that we could understand from those primary care providers, FQHCs more specifically, how many are interested, what are some of the barriers that they may see within their organizations. I know we're here to talk about solutions today, best practices. We're still trying to figure this out because our survey response rate was very low. And then amongst those that we did hear from, the interest wasn't very high. And so we have some subsequent conversations that are planned to try to delve into this a bit further. But it's certainly a reminder that providers need institutional support, from their practices, that, hey, this is something that we are going to do. This is something that's part of the care that we're providing to our patients, and for folks to get some mentorship in that process. So I think insurance companies can play a really important role. I know that we, for example, don't have prior authorizations around access to buprenorphine, and certainly, again, reaching out to providers are trying to make it easier and encourage folks to become prescribers. But that mismatch in terms of where the providers are that provide buprenorphine versus methadone is a huge issue. And to add one clinical story to it, I took care of a patient in the ER recently who was on methadone but fell out of compliance with the clinic. And so he went back to injecting heroin and basically came in on the brink of death, probably will have a limb amputated. And so when we talk about the deaths, that's the tip of the iceberg. Below that, we have a lot of individuals with severe illness, prolonged disability, and other conditions related to this very complex issue.
Thank you so much for kind of talking about some of the prescribing differences in various geographic locations around Chicago. Would you just kind of, in 30 seconds or less, describe what the difference is between buprenorphine and methadone for those who may not know?
Sure, I'll do it briefly and defer to my colleagues as well. Methadone is usually provided in a clinic setting where an individual has to go to the clinic on a regular basis to get their methadone pill, which will help address their cravings with regard to their opioid dependency. They have requirements around periodic drug testing. As an emergency medicine physician, over many years, I've taken care of patients who have missed their appointment and they're showed up in the ER because they can't get that treatment somewhere else. And it's a very difficult situation, right? Can they hold out another day, go through withdrawal, go and get their medication versus do I go back and use the drugs that I were using before? Whereas buprenorphine can be, you can get a 30-day supply. You can take your medication, you can go to work, you don't have to go stand in line, go to a clinic. So think about all the complexities that may lead someone down the journey of opioid dependency, and then the desire to just reclaim your life, to be able to be a productive member of society, take care of your family, kind of get unshackled from having to go to the drug pusher or the doctor's bottle, pill that you get, or to the methadone clinic every single day. That's a huge difference. And so when you see that individuals that live in one geography have access to a prescription and others have to go to the clinic each day, that's a problem.
The Center for Pew has recently put out a report on how restrictive policies in states limit access to medication-assisted treatment, including both. But there are two bills in Congress, the MAT Act and the MATE Act, both of which would help with some of those incentives for prescriber training as well as improving access just to medication assisted treatment overall and making it easier. Ms. Cathay, did you want to chime in? I'm sorry, I didn't. I thought maybe you had a question or follow up, but all right. Let's go over back to Dr. Dole from Steve Fund about prevention and treatment strategies.
Also, I just wanted to add in one more thing about the methadone. I think, you know, the idea of standing in your local neighborhood so that everybody can see you waiting to go into a clinic. You know, I live in Harlem for 20-something years, and there are methadone clinics, of course, in poorer neighborhoods where I lived, and the stigma of just going in there is preventative. And I think a lot of folks experience it as just you're addicted to a different drug that pharmaceutical companies are profiting off of you, and so it's just a different pusher.
With some public shaming added in
yeah,
there. With it.
Exactly. So it is a pretty complicated, and also, you know, where those clinics are situated, and, you know, you're not going to find one on the Upper East Side. And so, you know, it has those kind of implications. So you asked me the question about treatment strategies. Yes. Okay.
And prevention.
So, you know, I think you spoke really beautifully about the treatment that your organization provides, which I will say that level is unusual. So congratulations. It's really amazing. But I'm speaking as an outpatient clinician, and treatment strategies for us really are focused on harm reduction. And so the difference between abstinence model, which is 12-step, Alcohol Anonymous, which is, you know, you want to go through abstinence only. You're going to really try to not use. With outpatient clinicians who aren't necessarily substance abuse clinicians, you're really focused on harm reduction, meaning use a little bit less, and actually use other strategies like cognitive behavior therapy, dialectical behavior therapy to cope with mood, and mindfulness strategies. Those are all different ways that we as clinicians can address substance use. And then in terms of prevention, it's interesting because it starts with education. And you would think, you know, is elementary school too young to start talking about the harm of drugs and alcohol? No. It actually, you start to teach young people early on about the dangers of them without demonizing them, because you don't want to demonize their family members who may in fact be addicted to them. And so teaching young people strategies, coping strategies early on is actually a key to prevent substance use, because if you're someone who doesn't know how to cope with your anxiety, as I've mentioned, you might turn to a substance, right? You're going to, you know, everybody here is going to leave, and I imagine half the people here are going to have a cocktail when they get home, because that is in fact an effective coping strategy. Alcohol, drugs, they work to decrease anxiety. They work to make you feel better in the moment. And so teaching young people how to improve their mood through other strategies is really the key to prevention.
Excellent. I do remember I wanted to come back to Ms. Cathay to discuss a little bit about the financing, because we've actually seen a lot of residential treatment centers shut down. We're seeing even hospitals shut down, especially in rural areas. Can you discuss, I even this morning was at the Association for Behavioral Health and Wellness's conference, and one of the substance use treatment facilities said they pay $16 for 15 minutes. And with a team of clinicians, how do you stay afloat?
Both. I'm sure my boss is in the audience.
Wait, hold it.
I said my boss is in the audience, so he is waiting to see how I'm going to answer this question. And what I'm going to say is that a substance use disorder is the only medical disorder that's treated with grants. When so goes the grant, the ability to treat this disorder goes as well. We are on what's called a day rate. That means that everything we do that day is encapsulated in one rate. So our day rate is $299, and that gives you individual, group, medication-assisted therapy, that gives you physicals, that gives you food, that gives you sheets and towels. It does not it does not pay adequately for what we have to do. We receive money from state, federal, and city grants, but again, this is the only disorder that's treated with a grant. I mean, can you imagine if you had a heart attack and they said that the grant to treat cardiac arrest ran out, or we were not able to be funded this year. But this is what happens with substance use providers every year. Every year around June, July, we're wondering what our funding will be for that year and whether or not we'll be able to sustain certain services. What we try to do is figure out how we plot sustainability when we apply for a grant, because we know that the grant won't be with us forever. But yes, it is very difficult to provide this level of care on grant funding.
There is at least one person who agrees. To all the panelists, I think we have about 10 minutes or so, and then we'll open up the questions to the audience. Are there prevention, treatment, or recovery strategies that you know do absolutely not work in the Black community? And we did talk about some of the methadone treatment being regionalized. Are there other treatments or recovery strategies that you know are being touted, promoted, are used in training, and just don't work?
I'm going to start with misdiagnosis. And ignoring underlying problems. I think, not a specific treatment, but the specific behaviors that help with Black patients are those two specific things. If you are treating someone for substance use disorder, but you're not treating their trauma, you are not helping them.
I was going to speak about prevention. So most of my career has been in youth development, and I've built 2 prevention programs for young people. And you said I'm from Springfield, but I was born in D.C., and most of my work has been in the city. And so one of the things that I found out the hard way, because I went into prevention as someone who was learning from another organization, and that's when people who are not from a space come into a space to try to tell them how to be, especially with young people in the city. The first time I came in, I was sitting back and watching someone who wasn't from the city talk about the dangers of drugs and alcohol, as if alcohol and drugs were the problem. And, you're talking to people whose fathers and brothers have been sent up on charges for things that are now legal. And when you are only focusing on drugs and alcohol, you're separating their experience, the reality of their experience, from what you're trying to get as an outcome. And they see it and they smell it and they don't like it and they don't appreciate it and they don't listen. So I think we have to have more Black people who are in recovery talk about being in recovery. We have to have more Black people who are in media be unafraid to speak about what they learned the hard way, some of them going into the entertainment business, trying to live like rock stars as opposed to actually being musicians, and what that ended up being like. And when they hear that from people who came from where they came from, who quote unquote made it, it begins to have it brings a different connotation, right? And it allows us to then talk about the real problems of what they do or don't have, the coping skills that they have not been given, understanding the value of mindfulness and things of that sort from people who they admire. So that's on the prevention side. I don't do treatment.
I'll just be brief and say I think Joseph's comments are spot on. I mean, these are individuals that have instant brand credibility with an audience that is vulnerable and an audience that we really want to influence. And I think if we can assist them in leveraging that credibility to deliver a really important message around prevention, I think that'll be really, really great. And we can't start too early. I've had an experience in my household where a kid was at an extracurricular activity. A parent called and said, "Hey, my child said that someone tried to sell your child a drug." And so when I went to talk with my child about it, who was probably 10 at the time, he denied. Daddy created a safe space. You can tell me, you're not going to get in trouble. Denied. It was a couple of days before he came around to acknowledging what we knew to be the reality of that situation. And certainly as we talk about what's happening in our communities, we know that still methadone, heroin, fentanyl, major drivers of drug overdose deaths. And we've all seen the multicolored fentanyl-laced pills that look like Skittles. It's sort of like, oh my God, you gotta have that conversation with our young people, and we have to do it early. It's so important.
Thank you so much. I think one of the things that has just come up for me is whether or not we're having these conversations out loud. And so we are doing so today, and anyone who wants to tune in can tune in. Are these conversations that clinicians and workforce is having amongst themselves as well? Payers, payers, providers, and all of the kind of folks in roles that would be in the place that a person would go to for help.
Providers are talking about it, and what we're also encouraging our patients to do is to speak out as well, because the foundation of substance use treatment was anonymity. So individuals was taught to keep this disease quiet, not to talk about it, not to use your name or not to even say, that I have a problem. And what we're trying to do is to show there's evidence, successful completion, recovery is evidence that treatment works. So let's talk about it. Let's stand up and say, I am a person who has recovered, and this is what recovery looks like, so that more people will start to speak on it. And I think that is key. Providers are speaking about it, and we're telling others to speak about it.
I was just adding in response to your remarks. I think the messaging sometimes is mixed, right? When you think about the drug screening test that people have to go through for employment, that blocks a lot of people out of being able to get jobs. Sometimes there's some messages that aren't quite clear around acknowledging and a pathway to recovery. So I think those are things we got to really do some work on, not just the narrative, but also some of the policies that may serve as continued barriers.
Yeah, if I may add on that, I think the criminality of it is something that we have to talk about, because we understand that a lot of that criminality has been used to contain the black community. And when you want to have a conversation about the good or bad of something, and everyone's not playing behind the same rules, it also creates that sense of hypocrisy that makes communities just shut down and not listen. Like, are you here to help me, or are you here to take me to jail? And what is the relationship between the people in the community that are, like, if I can't come directly to your door, how do I get there? And if there's an intervention with a police officer, is that police officer given permission to take me to your front door, or does that police officer have to take me to jail? And understanding those rules in people's different cities and jurisdictions and so on and so forth. But also, I work with organizations that are looking to be able to tell the story of what they do more effectively to the communities. The distinction you made between methadone and buprenorphine, like, most people don't, know that the other one even exists. So the idea that they could get recovery without having to go to the clinic is not a reality that they exist in. And so harvesting the stories from people like yourselves who have thousands of them, and additionally giving people with lived experience autonomy over their story by sharing it in their community, but it's something that has to be intentionally sought after in how we do our social media from our organizations, how we work with the news to make sure that when the news is coming, the stories that they're telling are ones of triumph, so that when people are looking at the television, they're seeing, oh, I have a problem, but I can go and get help, and it's not the end of my life. I'm not leveraging everything I have to go get care, so on and so forth.
Sure. I just have about a minute left, so if each of you have one or two sentences about what you think the Congress or the administration or even state leaders can do, would you share to ensure that they're working on what matters to the Black community?
I'm just going to say simply, please give more money and allocate more resources. They think that would be my number one suggestion.
And not in grants. We need it sustainably.
We also need to focus on finding a spot for individuals with substance use disorders. We're often lumped in with behavioral health disorders. They don't quite fit with physical health disorders, and during the time of COVID, they tried to put us in with shelters. There was no place for a person.
Oh, that's right.
There was no place for a person for needing disease management.
The congregate care was left out.
Congregate care was left out. It was never even considered.
Yeah.
These were unhoused. These were people who were not related, living in a space for disease management, and there was no place for them to go. And I think more conversation needs to be around the stigma that's associated with substance use disorder and finding a place for treatment for those with substance use disorders.
In addition to their excellent suggestions, I would recommend that we focus on increasing the density of providers who prescribe buprenorphine in both the Black community as well as other communities that have high socioeconomic hardship. I think that's an important access and equity lever that we need to explore how to best accomplish that.
Thank you.
Culture change is as important as policy change. If people don't believe that there is a way to change, if they don't believe that life is actually or can be better without these substances, then there's very little chance of it catching. And that's just my experience working with young people and my own personal experience. I had to see it working to believe it could work. And we need to fund that type of advocacy also.
That exposure.
Can I add one more thing? Sure. You know, substance use isn't just for people who are lacking in resources. And I do think we've been talking about poor communities. Substance use is across all communities, in the Black community. And I do think that in wealthier families, it is a shameful secret that folks often don't get treatment, or their family doesn't talk about it. So I don't want it to be a misnomer. Only poor people have substance misuse. That is not true.
Oftentimes the others can pay out of pocket for whatever they need and keep that secret. Yeah. Thank you all so much. Are there questions from the audience?
Hi, I'm sorry. This is Anita again with senior. Yes. So the Congresswoman has to leave. So I think if we can wrap up the panel.
Oh, sure.
Then if people have questions, they can find the speakers.
Oh, okay. Questions. I just want to say I have to leave because they call votes.
Oh, thank you so much.
Or Congresswoman, if you want to go.
Kelly.
Okay.
We appreciate your work on this panel and Anita for helping to put everything together. This was a wonderful conversation, and hopefully we'll see each other again with some better news and some better outcomes that we can chat about. But thank you so much for joining today, and have a wonderful evening.